Hi, good morning, everyone, and welcome to the 2024 NICER Symposium kickoff. We are very excited to have you join us today for our masterclass in immunohematology as the start of our Through the Looking Glass Perceptions of Age and Disease in Immunoheme. I'm Kelly Wakovich. I am currently the executive chair in NICER, and for those of you who are not familiar with NICER, NICER is the North American Immunohematology Clinical and Education Research Consortium. We were established in 2016 with a mission to provide collaborative multi-specialty environment to advance the education, clinical care, and research involving the spectrum of pediatric and adult patients with immunohematologic disorders, really focusing on that intersection between immunology and hematology. We have three primary aims. One is to enhance communication between subspecialties. Two is to provide immunohematology educational opportunities such as this. And three, to establish and leverage a platform for cooperative research studies. We do have some formal organization to our structure with a memorandum of understanding and institutional members, and I'm so happy to say that we are up to 21 members, and we are looking for more. So if you are at an institution that you don't see on this list, feel free to reach out to learn more about how to become a member or an individual member if you're not sure you have institutional membership on the horizon. And it's not just providers that NICER is interested in collaborating with. While we certainly would like to recruit institutional members and individual providers, we are very interested in hearing from our patient advocacy groups and then our industry partners. So feel free to visit our website and click on these buttons to let us know a little bit more about yourself. And a big thank you for today's session. It is sponsored actually by one of our patient advocacy groups, Race for Immunology, who feels very passionate about bringing education to the wider group to help with early recognition of immune disorders. The meeting itself runs from Wednesday through Saturday, although of course today we'll focus on our first session, the Looking Glass House, an in-depth discussion on common immunoheme patient presentations. And with that, I'll hand it over to our excellent moderators, Dr. Chris Failing and Dr. Kathleen Overholt.
Thanks, Kelly, for the introduction. We have a really good set of lectures today, from hand and foot discoloration to iron deficiency anemia to angioedema, and the approach to when you should get an ANA and what to do with that when it's positive. So I'm ready to start whenever, I guess, if everyone else is ready for the first session. Let me share I'm going to share my screen here just to make sure everyone can see that. Can you see my screen?
Yes.
Okay, awesome.
All right. Well, I have the honor of introducing Dr. Failing. He is a pediatric rheumatologist at Sanford Children's and the University of North Dakota School of Medicine in Fargo, North Dakota. He's the Associate Program Director of the Pediatric Residency Program at UND and is the Medical Director of the Sanford Health Inborn Errors of Immunity Clinic. We just want to remind everybody, I will be moderating and monitoring the chat box, but there will be a Q&A session after all of the presentations. So please stick around and make sure you get your questions asked. So with that, I will let Dr. Failing take over.
Thank you. So my talk is called, Is This Raynaud's? Approach to Hand and Foot Discoloration. So as a peds rheumatologist, we get many referrals for this complaint, and this is one of my favorite consultations to do, especially in the frigid temperatures in North Dakota and Minnesota. We definitely see a lot more cases than you would down south. And sometimes it's not Raynaud's. People are told that by their primary care provider. When they come to us, it might be something completely different, or it might be a combination of two different things. So this will be, I have a lot to do in 30 minutes. So if someone wants to give me a heads up when there's 5 minutes left, just so I can make sure I get through everything. So my objectives are, we're going to identify the various causes of hand and foot discoloration in children and adolescents. We'll recognize the differences in signs and symptoms of Raynaud's phenomenon, acrocyanosis, erythromelalgia, and perniosis, which is also called chilblains. We'll recognize the complications associated with these conditions, and also outline kind of how you manage these conditions. So clinical case 1, a 14-year-old female presents with a 4-month history of episodic discoloration of her fingers with cold exposure. She has near daily episodes of her fingers turning white Usually when she works on her parents' farm, so she has to feed cattle in the morning, and in the winter when it's -10, -20 outside, she's having a lot of difficulty. They turn white and then blue. The color change starts usually in one finger, she's noticed, and it'll spread to other fingers. It spares her thumbs. And after it's white for a while, it turns blue. It resolves after 10 to 15 minutes of rewarming her fingers. She's had similar episodes when she's grabbing objects from the freezer. So whenever fingers come in contact with a cold object, they'll turn white. She's also had episodes when stepping out of a hot shower and any other hot to cold transitions. And this is really kind of interfering with her day-to-day life. The rest of her medical history is unremarkable. And on exam, she has normal findings. There's no evidence of digital pits. There's no ulceration of the digits. She does not have puffy, swollen hands or feet. And because you're a budding rheumatologist, you do a nail fold capillaroscopy and it shows normal nail fold capillaries. So she has Raynaud's phenomenon. So this was the first description of vasomotor instability was in 1862. And here's a picture of Dr. Maurice Raynaud. He was a medical student at the time. And there was I found a really good quote from his initial paper. It says, under the influence of very moderate cold, she sees her fingers become completely insensible and of a whitish yellow color. This phenomenon happens often without reason, lasts a variable time, and terminates by a period of very painful reaction, during which the circulation is reestablished little by little and recurs to a normal state, which is an excellent initial description of a patient. And the first term was kind of, they called it Raynaud's disease. It's more used to describe the vascular events until a Dr. Hutchinson argued that multiple etiologic factors could be responsible and kind of introduced the concept of Raynaud's phenomenon. It's actually initially thought to do with a problem with the central nervous system. So there were a lot of invasive procedures done to try to correct Raynaud's. And it wasn't until 1929, Dr. Thomas Lewis felt it could be due to local factors. So the pathogenesis of Raynaud's is very complex. You could spend a whole hour on this. So I'm just going to briefly kind of do an overview. There's really 3 mechanisms we think contribute to that. Decreased blood flow and blood vessel constriction, neurogenic responses, and inflammatory and immune responses. So the somatosensory system helps with temperature perception based on environmental stimuli. So when we're exposed to cold temperatures, there are certain receptors that are activated that result in cutaneous vasoconstriction and thermogenesis. Cold temperatures also activate the sympathetic nervous system to release vasoconstricting neuropeptides and norepinephrine, which leads to vasoconstriction of smooth muscle and decreased blood flow in the skin. So all of us, when we're outside, we have to maintain our core temperature. So that's why our hands and feet get cold when we're sitting out at a football game at the U of M for a long time or ice skating. And really in patients that have primary Raynaud's, which we'll talk about, when it's not caused by an underlying disorder, it's exaggerated vasospasm. So they've done these interesting research in these patients. They seem to have increased sensitivity of alpha-2 adrenergic receptors in the digital and cutaneous vessels. So instead of just clamping down a little bit, they clamp down a lot, and it could contribute to the symptoms of Raynaud's. The secondary causes of Raynaud's, really, it's the underlying disease that's a factor that disrupts normal vessel reactivity to cold temperatures. For example, patients with systemic sclerosis, they have fibrosis of the vascular system, which leads to endothelial dysfunction, endothelial remodeling, followed by tissue ischemia. So the clinical presentation, kind of the definition is characterized by recurrent episodes of exaggerated vasospasm following exposure to cold, and also stress. People usually forget about that. Some people just have episodes contributed by emotional states. So the clinical presentation, attacks often start in a single finger or toe, and spread to other digits symmetrically, involving both hands or feet. The fingers are more likely to be involved than the toes. In the area, the color change is very sharply demarcated. So initially, you might see a white color change, and that's due to ischemia due to constricted blood flow. Then you might see that change to blue, where it indicates tissue hypoxia. And then upon reperfusion of the tissues, the fingers might turn red. The color change is very sharply demarcated, so that's a key. You see a lot of kids that'll come in and say, oh, my hands get cold, they turn colors. But if they show you a picture, you don't see that really sharply demarcated color changes. So that's a key. And most people have pictures that you can look at. People might feel like pins or needles, aching or numbness. In secondary Raynaud's, it might be severe. They might have severe vasospasm and pain. And some have cutaneous basal spat at other spots too. So ears, nose, nipples, sometimes the skin over the knees. And one question is, do you have to have triphasic color changes to make the diagnosis? The answer is no. So in a really good retrospective study of 123 pediatric patients, only 24% of kids with primary Raynaud's and 19% of Raynaud's due to underlying disorder had all three color changes. Half of these patients just had one color change, usually pallor or the white color change. So when I'm approaching to a patient that could come in for Raynaud's, I like to ask the following questions. Are your fingers or toes usually sensitive to cold and or stress? Do your fingers change color when exposed to cold temperatures or stress? Do they turn white, blue, or both? Again, I ask for pictures. Every teenager has a picture of everything, so most of the time parents have it, and that can be really helpful in making a diagnosis. If they don't have pictures, I usually show pictures on Google of Raynaud's, and if people have it, they're like, oh yeah, just like that. I mean, it's pretty pronounced color change. If they're telling you, they don't really look like that, they're more kind of mottled, and it's probably not Raynaud's. It could just be cold sensitivity. And if people are unsure, I'll still have them send a picture. If they have their next episode, can you send me a picture? The patient portal, and I can look at. So if it's positive to all three questions, I'm going to do a deeper dive into the history. We're going to look at the distribution of affected sites. Is it just fingers? Is it toes? Thumbs involved, which can be a clue to secondary cause of Raynaud's. Ears, fingers, nipples, skin over the knees. Really want to focus on the frequency, the severity, and duration of attacks. So that's going to kind of help guide, is this need drug management, or can be managed without medications? The color pattern, is it monophasic, triphasic, biphasic? And then what things trigger it? So I want to know how does it affect their quality of life? I have some teenagers who they play softball in the spring months. I had a girl who has a scholarship to play softball in college and having trouble batting and throwing the ball because her hand should get Raynaud episodes during practice. So that's someone we treated just during the cold weather months. Compared to a kid that might work, their parents might farm, they have to take care of cattle, and it's flipping cold here in North Dakota, and it's really interfering with their ability to help their family out. Seasonality, it might be more prominent in the winter. Some people have it all year round. And then do they have any associated symptoms like numbness, tingling? Potential precipitating factors, frostbite. Certain medications we'll talk about, like stimulant medications, could cause Raynaud's. Smoking, secondhand smoke exposure, even vaping. Vibration injuries are a very uncommon cause. There might be a family history of primary Raynaud's. I see that quite often when there's multiple family members, or family members that have connective tissue disorders. Migraines too are another secondary cause of Raynaud's. One really important one is weight loss and anorexia. So maybe one kid a year I picked up that has anorexia nervosa. So just because their BMI is so low, they're trying to maintain that core temperature, that their vascular system is so clamped down that they will have acrocytosis, which we'll talk about later, is usually Raynaud's as well. You want to ask any questions for features that could be suggestive of a systemic autoimmune rheumatologic disease. Again, you're going to get ask much more questions as this, but a really comprehensive RIA system. So I'm asking about changes in the digits. Do they have any sores, ulcers, blistering, any wounds that are not healing well? Hernia, which we'll talk about later, which sometimes can occur with Raynaud's. Do they have fever, myalgia, muscle weakness, dysphagia, GERD, which you might indicate someone with limited or systemic sclerosis, skin thickening, sclerodactyly, cardiopulmonary symptoms. But also, again, you want to get a really full review system for these patients, because you don't want to miss a secondary cause. And that's the most important thing when we're seeing these patients. Is this just Raynaud's by itself, or is there something driving the symptoms? So the causes are extensive. So primary Raynaud's probably makes up about 80% of pediatric cases when you look in the literature. These are usually girls, ages 15 to 30 years. Girls more than boys. Rarely do you see it in kids much younger, but I've had some kids that have primary that are 4 or 5 years of age. But we'll watch them a little more closely. Rheumatologic diseases we think about, including lupus. Systemic sclerosis is a really big one, especially in adult patients, where it could be the presenting feature of the disorder. Sjogren's disease, mixed connective tissue disease, which is overlapping features of lupus, scleroderma, dermatomyositis in the setting of a very high positive RNP antibody. Dermatomyositis and polymyositis, which are the inflammatory myopathies, and we have autoinflammatory diseases too that have Raynaud's and other perniosis chilblains at a really young age, such as the interferonopathies. Hematologic disorders we don't see as often in kids with this. Cryoglobulinemia, especially type 1, which is usually in older adults that have an underlying malignancy. They might have severe Raynaud's with evidence of tissue ischemia. Paraneoplastic disorders, cold agglutinin disease, which has been more common in adults than kids. Endocrine diseases, I will sometimes screen for thyroid disease in these patients. Maybe 1 or 2 patients present that way. Carcinoid and pheochromocytosis have been reported as well. From a neurologic standpoint, migraine headache, migraines can be associated with a vasospastic process, so some people that will have Raynaud's. Vascular, less common in kids, but you might see things like thoracic outlet syndrome, emboli, systemic vasculitis, including things like systemic polyarteritis nodosa, or Takayasu's arteritis, atherosclerosis, which are again uncommon in children. But this might present, the clues might be more like an asymmetric, very painful Raynaud's, or Raynaud's confined to just a single digit. There's many drugs that can cause secondary Raynaud's phenomenon, including stimulant medications used for ADHD, some chemotherapy agents. Obviously, hopefully kids are not doing cocaine, but you never know. Nicotine, interferons. Then again, smoke exposure is another big one. So on exam, you're really looking for any areas of tissue loss. You want to look at other areas affected by cutaneous vasospasm and look at those closely, like the ears, the nose. You want to do a very thorough musculoskeletal, cardiopulmonary, and skin exam. As you do peripheral pulses, just look for any evidence of proximal or large vessel disease. A nail fold capillary by gross exam and by microscopy. And here is a picture of a patient with systemic sclerosis. He has lost a digital pulp on his index finger. You can also see digital pits on most of his fingers, and on his third finger at the tip there's a digital ulcer. This is a patient with scleroderma as well who has sclerodactyly, so that's that localized thickening and tightening of the skin that results kind of like claw hand-like deformity. Here's a picture of a patient with dermatomyositis. So you can see just grossly there's changes with the nail fold capillaries. There's periungual erythema, there's telangiectasias you can see visibly with your eye. This patient also has pretty significant cuticle overgrowth as well. So nail fold capillaroscopy, I think, is a pretty cool thing. It's really important when you're evaluating patients with Raynaud's because it's going to really allow early diagnosis of some of the diseases we treat in rheumatology. So we're looking at a lot of different things: visibility, morphology, diameter, length, the distribution, the density of capillaries over a millimeter. Is there any areas of microhemorrhages? It's pretty cool because a lot of the vessels in the skin run perpendicular to the skin surface, but the capillaries run parallel, so it allows us to visualize them much more easily. Here's a picture of normal nail fold capillaries. You can see they all look uniform. The morphology is the same. They kind of have this U-shaped kind of hairpin-like appearance to them. There's good density if you measured them over a millimeter. I think the normal is like 9 to 12 in a millimeter. There's none that looks dilated. Now, if you compare on the right here to someone that has scleroderma, early findings, you can see some areas of normal nail fold capillaries, but there's giant ones that have really a dilated vessel wall. There's areas of microhemorrhage. So a very important thing that we look at in all patients that come to us for Raynaud's. So primary versus secondary, there's some clues. So primary, usually women more than men, ages 15 to 30. Secondary can occur at any age, but if you have someone with Raynaud's that develops after age 40 years, it's always pathogenic. So between 30 to 40, it's a gray area. Attacks for both might be precipitated by cold or stress. Primary usually is bilateral, symmetric. It tends to spare the thumbs, where those with secondary might have asymmetric attacks that are much more painful, much more severe. They can involve the thumbs. You're going to see findings sometimes of ulceration or ongoing ischemia versus which you shouldn't see in someone who has primary. Primary patients, again, that's where the nail fold capillaries are really important. They should be normal. I think in the literature, there's reports of maybe you might have a few that look a little abnormal, but you shouldn't see really grossly abnormal findings. In patients with primary, they do not have autoantibodies. So those that are secondary, they usually have abnormal nail fold capillaries. They might have a specific autoantibody like SLE70, which can be seen with systemic sclerosis. They might have signs and symptoms of another disease as well when you're doing their exam or by review of systems. So lab testing, if you have someone that's likely primary, meaning they have, it's pretty mild, there's no evidence of tissue ischemia, there's normal nail fold capillaries. Some people would argue you don't need any lab studies. I think where I trained, I usually do check an ANA and some other basic lab studies. I think it's still important because it could be, again, a really early finding of underlying problem. But I know at some places they won't. That's not a study that they will check, but I usually do if someone has true Raynaud's phenomenon. And if, say, for example, there's some of the nail fold capillaries look a little off or they're abnormal, I might have them come back in 6 to 12 months, just so we can kind of closely monitor things. If you think more of a secondary cause, you want to do more of a workup. Now, we have people traveling 10 hours to see us here at Sanford Health, and I think a lot of times people are very worried, and a lot of times we'll end up doing more of the initial screen for these patients. So getting a CBC, a CMP, UA with urine sediment to look for any evidence of proteinuria, hematuria, an ANA, ideally by indirect immunofluorescent testing, a TSH, you can do ESR, CRP, and the rest of it, the testing is really dependent on what you find on exams. Obviously, if you have someone that has really grossly abnormal nail fold capillaries, you're going to send more antibodies, maybe for systemic sclerosis, complement levels. You think someone's going to have lupus. If they have findings on exam or by history that are suggestive of inflammatory myopathy, and getting your muscle enzyme, CK, aldolase, LDH, and myositis-specific antibodies. Now, if they have single-digit or asymmetric attacks, asymmetric blood pressures, absent pulses, that's where you ought to really think about doing vascular imaging for these patients. So treatment for uncomplicated Raynaud's. So kids that have primary Raynaud's, majority of these patients do not need drug management. So you really want to focus on what can you do to help prevent episodes. So education on avoiding triggers. Now, if we talk about avoiding cold in Minnesota and North Dakota, people laugh at us because it's hard to do that. But the big thing is wearing warm layered clothing. Teenagers they come into our clinic, they might have Raynaud's and it's -20 out. They're wearing Chuck Taylor shoes. They're wearing a light coat. They don't have gloves. So really providing education on you have to keep your core temperature warm. So warm coat, warm hat, boots and socks. Mittens are not stylish, but they keep heat in better. It might help prevent flares. Stress reduction, if they have, if that's something that's driving them, that's a little more tricky sometimes, coping skills. You want to discontinue smoking. Lots of teenagers vape, so ask a lot of them about vaping and smoking, other medications they might be taking. And then to help alleviate or resolve an episode, we'll go through things like massaging the hands, you might put in warm water, windmill maneuver, swing arm maneuver, and you have your armpits. They're great for keeping your hands warm. So you can tuck them in there or anywhere else. Some people here will use a lot of like hand warmers they'll put in their gloves. That can be helpful too. So if you have someone that, rarely do kids with primary need medication, I'd say up here we have more kids that probably need it, especially during the winter months, and depending on how it's affecting their day-to-day functioning, if they're having multiple episodes a day or it's interfering with sports or their work or school, that's a reason where you could treat them. First-line therapy for both adults and kids are dihydropyridine calcium channel blockers. So you want to use a long-acting or sustained release. So there's nifedipine, amlodipine. I like to use nifedipine. My colleague uses amlodipine. Doesn't really matter which one you choose, but you want to start at the lowest dose and titrate depending on response. Every kind of 3 to 4 weeks, you can increase the dose more. Sometimes you can do it faster than that. That's what typically I will do. You want to start out usually at 30 milligrams a day for nifedipine. You can go up to 180. Amlodipine comes in 5 milligram tablets. For younger kids, you might start with 2.5. You can go up to 20. So there are side effects. So dose-dependent peripheral edema. So in adults, if they have someone they're worried about systemic sclerosis, they sometimes don't want to use amlodipine because they get puffy, swollen hands. Is that from the medication, or is it their disease is evolving? Kids might get flushing, gastric reflux. It can cause headaches. So if someone already has baseline migraines, it can be a little tricky finding what agent to work. And but overall, they're pretty well tolerated in general. Now, if they have low blood pressure, a kid comes in, I might have them do some monitoring at home just to make sure there's no change in that. So say they have a partial response, in secondary Raynaud's phenomenon, It's really unrealistic to eliminate attacks completely. You want to really reduce the frequency and severity of them to improve quality of life. With primary Raynaud's, you should be able to eliminate attacks with these patients or significantly reduce the burden. Now, if they have a partial response to a calcium channel blocker, you could try switching to an agent, trying to up the dose more. If that doesn't work, you can add typically a phosphodiesterase inhibitor, sildenafil, which is Viagra. So 20 milligrams daily, up to 20 milligrams 3 times a day. This can be hard to get approved from insurance. I've had issues sometimes getting it approved. And again, if someone had no response to calcium channel blocker, you can do monotherapy with phosphodiesterase inhibitor. Other treatment options like direct vasodilators, like topical nitroglycerin. I don't use this too often. You don't want to use that in combination with sildenafil because it can cause severe hypotension. There's lots of indirect vasodilators too. I've had actually someone use fluoxetine and SSRI that actually had good improvement. I haven't really used other ones because usually the other drugs work pretty darn good. Endothelin 1 antagonist might be used for kids that have like systemic sclerosis. So critical digital ischemia, where there's a patient might come in with irreversible vasospasm, findings of ulceration, they're at risk of losing that digit. These are patients that have to get hospitalized, and this is really doesn't happen a lot in kids, but kind of the recommended management is you want to start a short-acting calcium channel blocker and then titrate aggressively to the maximum dose tolerated before switching to a more longer-acting one. Some people might do local injections of lidocaine at the base of the fingers and repeat it. Now, if you're doing a combination of those two things and it's rapidly advancing, some people will propose using heparin. The literature on that is a little mixed. And then IV prostaglandins or prostacyclins. Now, if there's no response, hopefully not, there's other things you can do like angioplasty, sympathectomy. And again, really, we saw one patient in fellowship where this happened, but she ended up having auto amputation of her digits. So early recognition and treatment is critical. So clinical case 2, it's a female teenager that comes in with blue hands and feet. Her hands and feet always feel cold and clammy. They often have a just diffusely blue purple discoloration. She describes them as looking dead. The color change is poorly demarcated and involves the entire foot and hand. It seems to be, it's kind of always there, but when she's around cold temperatures, like walking barefoot in the house, it seems to get worse. She has no symptoms with this at all. And the color change improves when the limb is placed horizontally. Her past history, she has ADHD and she takes Concerta. And she has a normal exam. There's no evidence of anything suggestive of a connective tissue disease. Now on exam, she has bluish feet, both sides, kind of extends up to the ankle. It's poorly demarcated. There's no clear area of demarcation. They feel really cold, so you touch them. She always says her feet and hands feel ice cold. When we do her capillary refill, it's very prolonged, and it refills from the periphery to the center. We call that a Croc sign. And then after you elevate her legs for 2 minutes, the color change goes away. So this is acrocyanosis. So it's commonly a benign condition. You can see it in other places too, like people might have it in the lips, ears, but most commonly in the hands and or feet. So primary acrocyanosis, again, there's no comorbid diagnosis. This is really common in adolescent females. Secondary acrocyanosis, you might see a big culprit is stimulant medications. It might cause it or actually exacerbate the acrocyanosis. Anorexia nervosa, as we talked about before, this is a really common finding in those patients. Rarely reported with benign and malignant neoplasms. POTS, that is a pretty common finding, and usually the acrocyanosis can extend up into like the calf or leg. Might see it during certain infections, spinal cord injuries. It's also been reported in patients with Ehlers-Danlos syndrome and other heritable disorders of connective tissue. So how we treat it, it's really reassurance. It's a benign condition. There's no long-term complications. Avoiding cold is one way. And then really kids just need to drink more fluid. Teenagers do not drink enough water. So really trying to push fluid intake can help. Rarely do you have to change ADHD medications because kids, it's more of a nuisance. They look funny, but it doesn't cause pain, it doesn't interfere with their daily functioning. So rarely have I had to make those changes. People sometimes they're like so purple that people are sent to the ER because they think that something's like there's no blood flow to the area or they're going to lose their foot. Clinical case 3. So this is a 14-year-old male who presents with episodic burning and redness in his feet. So episodes, one thing to mention too, I forgot, with acrocyanosis, that can occur a lot with Raynaud's phenomenon. So it's not uncommon to have both. In the clues, you might see like a purple hand, but the fingers are white. There's that sharply demarcated color change in the fingers. So those do go, no pun intended, hand in hand a lot. So back to case 3. This kid, teenage boy, has episodes of this acute, severe burning pain with, like he says, lobster red, like color change, warmth and swelling in both feet. Symptoms are brought on by exercise or heat exposure. He has a hard time wearing socks because it might trigger episodes. He puts his feet in like cold water, it helps. At nighttime, he likes to keep blankets off his feet, likes to keep his legs elevated and have like a cool fan blowing on them. So this is erythromelalgia. Some people may have heard of this. It's a pretty rare condition of episodic vasodilation. Think of it the opposite of Raynaud's phenomenon. So these patients will have episodic burning pain. They tend to have significant color change, warmth if you touch the affected extremity. Usually just affects the hands and feet, but it can affect the extremities too in some cases. And it's usually precipitated by changes in ambient heat exposure. I had a girl who was a soccer player who had trouble playing because her hands and feet would get involved when she was playing soccer. And it's alleviated by cooling measures. So a lot of times people want to put something in cold. Some people actually cause injury to their hands when they're putting them in cold ice baths too often. It's a really tricky thing to treat, and it can be very severe sometimes. I've had a patient in the past who contemplated suicide because these episodes were so severe in intensity. So there's primary and secondary causes. So primary usually starts in childhood. There's a familial form of it or sporadic. So it's usually much more difficult to treat. And we do know in both sporadic and familial cases, there's gain of function mutations in a gene that encodes a voltage gated sodium channel. The thought is that it kind of stays open permanently and leads to some of the neuronal activation that leads to pain. If you have a loss of function mutation in that gene, you have you have pain insensitivity. Secondary, this is usually more in older kids and adolescents. So a majority of these cases are caused by essential thrombocytosis or other myeloproliferative disorders. And this is great. You can give them aspirin and it works like magic. Like their symptoms go around and you're a hero. Other things you might see in small fiber neuropathies, sometimes it's been reported in some autoimmune disorders, including lupus. But overall, it's a very difficult thing to manage unless it's due to essential thrombocytosis. So treatment, their Mayo Clinic has a kind of a guideline, but it's really trial and error. So all patients, you want to try avoiding triggers if possible. You want to cool the affected area safely. Ice and water immersion should be avoided or limited to less than 10 minutes at a time or less than 4 times a day. First line therapy, you want to try topical therapies, at least a 4-week trial at least. I've used lidocaine patches. You can get them over the counter. You can cut them up into squares and put them on the dorsum or the palms or soles of the feet. You want to do 12 hours on and 12 hours off. So the patches work better because it's more of a sustained release than the creams. Some of these other things are harder. I've used diclofenac gel, amitriptyline. Those are really tough. Just you have to find a compounded place to do that. Aspirin doesn't usually work for primary if you don't have myeloproliferative disease. You can trial it, but I haven't had good success. Maybe in one patient I've tried one time and it worked. But it's really tough. And I think sometimes this condition actually occurs with Raynaud's phenomenon. I have one boy who has both. If you think about it, it's a terrible cycle, right? You want to cool your hands when you're having erythromelalgia, but that causes Raynaud's phenomenon, and you warm them again. So you had this vicious cycle he was going in and out of. And we tried lidocaine patches that helped a little bit. We actually put him on a calcium channel blocker. It hasn't really been reported to be effective, but in some cases it does, and it has seemed to work really well in managing both. SSRIs, I had another girl who had pretty severe episodes and got put on fluoxetine for depression, and it reduced the frequency and severity of episodes. There's some evidence in literature too that if this is caught early, some people will do steroid therapy, or pulse steroid therapy has been reported too, but it's unclear how effective it is. NSAIDs I haven't really used a whole lot as well. So perniosis, I think I got a few minutes left here, or chilblains. And you might have heard a lot about this when COVID is going on. There's chilblain, COVID toes. That was chilblains. This is a rare inflammatory condition that typically affects the acral skin and primarily results as a response to cold, damp conditions. So patients will present with symmetric, multiple erythrocyanotic macules. It could be papules, it could be nodules, affecting the bilateral hands and feet. They can affect any part of the hand or foot, but commonly on the dorsal surfaces. You might see it on the fingertip or toe pads. It's not like Raynaud's where you have cold exposure, and it does not have to be to non-freezing temperatures. It usually is delayed, so within 24 hours of exposure, they might come on. And they usually resolve within a few weeks. However, some people might have a chronic course. They do not resolve with rewarming. So we'll get referrals. Someone thinks this is Raynaud's phenomenon, but you look at their hands, these are permanently present. They try warming them up, the lesions don't go away. They can really hurt. Some people describe it as a burning like pain or itching. They sometimes can blister or ulcerate. That can predispose you to maybe getting a secondary infection, which is a major complication. And some people with Raynaud's, if their Raynaud's is poorly controlled, might develop perniosis as well. So treatment, you want to, again, avoid triggers. So especially cold, damp conditions. So if you have someone who's playing hockey, they have really sweaty feet and socks, they don't take them off, it cools, that might cause a flare. So wearing smart wool socks is really good. It reduces perspiration. I've had some people use like a foot deodorant spray. If the palm, they have really hyperhidrosis of the palm, they can use like aluminum hydroxide, like a deodorant for their palms. Steroids can be helpful. In the literature, there's not really a lot of clear what is efficacious for this disease, but if you're using them, you want to do medium to high dose corticosteroids. Usually, if they last for weeks, that's just a natural progression, or do the steroids help? In kids that have had more of a chronic course, I found it to be helpful with flares, but you want to use it the shortest duration as possible, just to reduce risk of side effects like skin atrophy. Nifedipine has been shown in some patients to resolve lesions faster and prevent episodes from recurring. I have one girl who had very severe recurrent perniosis that we treated with nifedipine, and she's doing much better now. Chilblains lupus erythematosus are the rarest form of chronic cutaneous lupus. So it occurs in both sporadic and inherited conditions. There's a TREX1 mutation in that gene that's associated with familial Chilblains lupus. The clue with these is usually the lesions occur all year round, even in warm weather months. And a lot of these patients are going to have positive ANA, Rowan law is very positive, hypergammaglobulinemia. They might have positive antiphospholipid antibodies. It can be diagnosed with a skin biopsy. You can see characteristic changes. However, other chilblains, it's not super helpful, but you can see things that might be suggestive of just regular chilblains. I do have one girl with this, so we did biopsy, put kind of the classic signs and symptoms. How you treat this is how you treat chilblains in general. Again, with nifedipine, they just need close following for progression to systemic disease, which can occur in around 15 to 18% of patients. And lastly, there's genetic interferonopathies that can present with both Raynaud's and chilblain-like lesions. These usually occur very early on in life, in infancy. So Candle syndrome, they might have perniosis-like lesions on the ears, nose, fingertips brought on by cold. That tends to get better as they get older. But with conditions like Sting and Sabby, they might have severe perniosis that might lead to tissue ulceration or tissue loss. AGS too, about 1/3 of patients, if they have a TREX mutation, they might have chilblains. And it's also been reported in data too as well. So this is a nice summary table that I composed. So again, just reviewing Raynaud's, again, primary is usually 15 to 30. Acrocyanosis, again, more common in females. Pernio can occur at any age. Primary erythromelalgia usually starts in childhood, but secondary causes later in life. Again, a lot of these, it's with primary Raynaud's and acrocyanosis, the trigger is cold. Pernio, it's usually cold, damp, non-freezing temperatures, and erythromelalgia is the opposite, heat exposure. Primary Raynaud's and erythromelalgia are more episodic, whereas acrocyanosis might be more persistent, and Pernio tends to last for days, weeks, sometimes even months. Most of them are symptomatic besides acrocyanosis. Most are readily reversible except Pernio. Acrocyanosis, if you elevate the limbs, you might see improvement of the discoloration. And again, distribution, mostly hands and feet for acrocyanosis, primary Raynaud's. Hernia, you can see in other places too, but usually on the finger pads, toe pads, nail folds, dorsum of the hands and feet. Erythromelalgia is again hands and feet. So then treatment, as we kind of talked about before. Thank you very much. Hopefully you learned something about hand and foot discoloration. So next time someone comes to you and they say they have Raynaud's, you might have some good questions to ask.
All right. Good morning, everyone.
Sorry. Thank you so much, Dr. Phelan, and thank you, Dr. Jesuitis, for being here to see our to present today. I hope I am saying your name correctly, but Dr.
Yes, you are.
Jesuitis is a pediatric hematologist at St. Jude Children's Research Hospital and consulting hematologist at Lon Bonheur Children's Hospital in Memphis, Tennessee. He's the lead physician of the General Hematology Service and has been part of NYSER Consortium since 2016. And he is here to discuss understanding iron deficiency in the setting of inflammation with us. So welcome, and I will let you take over the screen for your slides.
Perfect. I'm going to try and share with you. Okay, let me see. How does it look? It is not in presenter mode, right?
Correct.
Okay. Okay, how about now?
Yes, perfect. Thank you.
Let me see if you can. All right, so good morning again, everyone. And I'm going to spend the next half an hour or so talking about iron deficiency, anemia, and inflammation. These are my disclosures. They have nothing to do with the presentation. The objectives are to evaluate the complex relationship between iron deficiency, anemia, and inflammation, apply concepts of iron metabolism and inflammatory pathways to identify patterns and clinical presentations of iron deficiency, anemia in patients with inflammation, explain how these patterns can inform diagnosis and treatment strategies. So I'd like to start with this tweet that came across. This was when X was Twitter, and I was preparing an iron deficiency talk. And I don't know who this person is, Toby Richards, but he made the statement that there's a disease called iron deficiency anemia that very few hematologists know much about or are interested in. And William Aird, who's an adult hematologist, said that this was his favorite outpatient referral. The histories are fascinating and the treatment is rewarding. And I hope that by the end of this talk, I can convince you that one, I'm a hematologist who is interested in iron deficiency anemia, and two, treating your patients who have iron deficiency anemia can be very rewarding as well. So with that, a little bit of physiology. We absorb about 1 to 2 milligrams of iron daily. Our bodies are designed to prevent us from absorbing more iron than about 2 milligrams a day, primarily absorbed in the proximal duodenum. Ferrous iron is absorbed better than ferric iron, and heme iron is absorbed better than inorganic iron. Clinical history, again, there is this laundry list of symptoms, which you probably all remember from med school. Pica, the pictures on the side are Pica, kid who decided to eat the corners of her books and also the label of the ferrous sulfate bottle. And as you can see, none of the ferrous sulfate was given to the child because the label was eaten. Fatigue, sleeping excessively, dyspnea on exertion, all non-specific symptoms, headache, lightheadedness, decreased endurance or performance, neurocognitive decline, restless leg syndrome, more commonly in adults, bleeding symptoms, and increased risk of thrombosis. Increased risk of thrombosis we've known, and we have we have known for a long time. Bleeding symptoms more recently has come to our attention, and this is because you need iron for your platelets to function properly. And there have been few studies that have showed that if you correct the iron deficiency, one, the platelet function improves, and also the iron deficiency, the bleeding symptoms improve as well. So very non-specific symptoms. So if and most of your patients with inflammatory conditions have other reasons to have all of this, but I hope this talk will convince you that it may be worthwhile evaluating for iron deficiency as well. Lab findings are, the examination findings, sorry, are pretty straightforward. Pallor, tachycardia, presence of a cardiac murmur, absence of jaundice, and hepatosplenomegaly for plain iron deficiency anemia. Your peripheral blood smear, microcytic, hypochromic, anisocytosis, and thrombocytosis. So again, if you're not a hematologist, you probably won't be looking at a peripheral smear, but sometimes it may be worthwhile looking at the comments that the pathologist or the person who's reviewing the slide makes. The differential diagnosis, thalassemia trait, is something to always consider when you have somebody with microcytic hypochromic anemia. Most states now have a newborn screen that report BARTs if they find it. That may be seen in alpha thal trait, which is particularly common in the African American population. The Menser index is something we talk more about than we actually use in practice, but your MCV by your RBC count in millions, a number more than 16 most likely suggests iron deficiency, less than 13 suggests your thalassemia trait. Sometimes it may be worthwhile to either review a CBC of the patient or of the parent if it's available, or just ask the parent if somebody has diagnosed them with thalassemia trait. And another thing to look for in the peripheral smear report is to see if target cells are reported. That's again not very specific. You may also see it in conditions like liver disease, which sometimes patients who are inflamed may have. But if there are target cells, it may be you might want to think about having the patient having a coexisting alpha thal trait, anemia of inflammation. ESR and CRP are the common biomarkers that we look for, and the serum soluble transferrin receptor is something that we more frequently use to evaluate for iron deficiency anemia that's coexisting with anemia of inflammation. So a little bit more about how your iron needs to get to where it's supposed to. It needs first to be absorbed by the gut, transported in the plasma, put into blood cells, that is, and also stored away in the liver and the reticuloendothelial system, and also recycled. And then after that, recycled. Again, remember, you're only absorbing 1 to 2 milligrams a day of oral iron. So how does it traverse the gut? It first needs to get reduced to the ferrous form. If it's in the ferric form, then it gets transported in by the DMT1 transporter, and then it is exported by ferroportin. It's then again oxidized into the ferric form, and then it is transported in the blood with transferrin. And in the last, the heme ion is transported through the HCP. It's then oxidized to the ferrous form, and then it's transported again to out of the cell through by the ferroportin transporter, and then bound to transferrin. It's transported in the circulation. More recently, we've understood that hepcidin, which increases in inflammation, blocks your ferroportin to export out the iron into the circulation. And this has been an area of a lot of research. It hasn't made it that much into the clinical evaluation yet, although I think there are a few labs that are able to measure your hepcidin. Now going into the cell, your iron, oops, sorry, this didn't quite come out, but your transferrin needs to bind to the transferrin receptor. Can you see my arrows? Can you see my arrow, my marker? No? Oops. Let me see if I can.
Yes, I can. It's small.
Oh, you can.
You can
Oh,
see
okay.
it, yes.
Sorry. It needs to come into the transfer, bind to the transferrin receptor, get internalized in the endosome, get converted into the ferrous form, again, and then get transported into the mitochondria. And then your transferrin receptor gets recycled out again. So there are two types of iron deficiency, absolute iron deficiency, and in inflammation, we see what is known as the functional iron deficiency. And these pictures, I think, if you can remember this from this talk, that's pretty much all you need to understand about iron deficiency. So in your absolute iron deficient state or your classical iron deficiency anemia, your body, the liver senses there's a decreased amount of iron in the blood. There's decreased amount of hepcidin that results in increased ferroportin that helps iron get transported into the circulation from your gut cells and also from the storage forms as well, both in the liver and in the macrophages. Your iron gets pushed into the circulation. There's also increase in transferrin. So your total iron binding capacity or your TIBC goes up. And this basically helps iron get transported into the bone marrow for erythropoiesis. When you have, on the other side, when you have functional iron deficiency in any inflammatory conditions, your IL-6, IL-1, TNF, they increase the production of hepcidin. So you have a lot more Hs in the circulation. That results in increased degradation of ferroportin, which is reflected by lot fewer Fs on your enterocytes or your liver or macrophages, and so your transferrin is also decreased, and there's also a decrease in your transferrin saturation as well. Most of the iron gets stored in the form of ferritin, and your serum ferritin also goes up. So that is, to summarize, the two types of iron deficiency you will be dealing with in your patients with inflammation. There are multiple mechanisms that contribute to iron deficiency anemia and inflammation. It's kind of a theme in CKD. So there's reduced iron absorption, and two, there may also be increased iron loss in CKD and heart failure. There's and also sometimes in liver disease, there is GI tract edema. You might be using proton pump inhibitors, which can alter the pH of your gastric acid and thereby prevent absorption. Phosphate chelators. There's also high hepcidin, which goes with all inflammatory conditions. There in inflammatory bowel disease, again, it's high hepcidin, blockage of diurnal absorption. There may be patients who've had their small bowel removed. Obesity, again, high hepcidin due to adipose tissue inflammation and post-bariatric surgery as well. Liver disease, GI tract edema, and diarrhea caused by laxatives, rheumatological conditions, which some of you may deal with more often, high hepcidin with blockage of intestinal absorption. Increased iron loss is it's usually GI or uterine blood loss. So always think about that as well when you are evaluating your patients with iron deficiency anemia. Lab diagnosis of iron deficiency anemia. Again, this is generally thought about when you are dealing with plain iron deficiency anemia without inflammation. Ferritins less than 15 is considered to be, when you're looking at the storage forms, is suggestive of iron deficiency anemia. Increased serum transferrin, low transferrin saturation. We also sometimes look at the reticulocyte hemoglobin content or equivalent. Again, we don't have standardized values yet, but less than 26 picograms, some people say 29 picograms is more reflective of iron deficiency anemia. Your hemoglobin, again, it's based on your age and gender. So it may be different for different groups of patients, but always, and when you have this condition, when you have these labs in combination, you can almost certainly be sure that your patient has iron deficiency anemia. With inflammation, things change a bit, which is why I did not include it in the table, but I'll discuss it over the next few slides. Soluble transferrin receptor is a lab test that we've been using more frequently. It is a circulating protein that is derived from cleavage of the membrane transferrin receptor on your erythroid precursors in the marrow, and it is inversely proportional to tissue iron availability, and it is useful in chronic inflammation to identify patients who would benefit from iron therapy. And this sometimes, I think some in payers as well kind of mandate us to send out soluble transferrin receptors, especially if you're thinking of using IV iron for some of our patients. So when you look at iron deficiency anemia and the combination of iron deficiency anemia, you can see that there are a lot of patients who are who have normal ferritins, at least not above our cutoff of 15, that could have iron deficiency in combination with anemia of chronic disease. But when you use the soluble transferrin receptor at a cutoff of 3, you identify most of those patients to have iron deficiency anemia as well. And when you use a soluble transferrin receptor to log ferritin index, the difference is even more clearer. What I would like to highlight also is the fact that this soluble transferrin receptor, and I did not realize this until I was preparing for this talk, was first described in 1997. So we're almost 30 years away from having this test being described in iron deficiency anemia and conditions where you have iron deficiency anemia and inflammation. But it's still sometimes a challenge to get this approved by your payers, or if you send too many of these, you might get an email from your administrators. But it is a useful test that helps us differentiate both identify patients who have both iron deficiency and anemia of inflammation. So putting it all together, I've tried to combine, at least the slide has tried to combine conditions where people have evaluated for iron deficiency anemia using the gold standard, which is bone marrow aspiration and evaluation of iron stores in the bone marrow. And as you can see, the normal bone marrow iron and the bone marrows that are iron deficient, there is areas of overlap. So there is no definitive cutoff for patients who have iron deficiency anemia in inflammatory conditions. Ferritins of up to 500 have been reported, particularly in heart failure patients. Your transferrin saturations almost always, if it's less than 20, you are most likely dealing with iron deficiency, some form of iron deficiency, whether it's pure iron deficiency anemia or a functional iron deficiency. So again, putting it all together, if you have a ferritin of less than 30 in a patient with inflammation, most likely you're dealing with iron deficiency. Of course, your transferrin saturation should be less than 40 or 45. As your ferritins go up less than 200, you are most likely dealing with iron deficiency in chronic inflammatory conditions. Less than 500 in kidney disease and heart failure. More than 500, it's unlikely that you are having you are having true iron deficiency. You might want to think of um, uh, agents like EPO that can stimulate your marrow to increase your hemoglobin if that is still a challenge. The treatment of iron deficiency anemia. So this is then other tweet that I came across where Anna Kendrick was asking if there are iron supplements that don't taste like a dirty penny. So one, I don't follow Anna Kendrick, but that still came across my feed, which I thought was interesting. And two, I think someone as rich and famous as Anna Kendrick also has problems finding a good iron supplement. So I thought that was interesting. General treatments, again, correct iron anemia urgently if there's evidence of severe anemia or cardiorespiratory instability. And when you're correcting iron deficiency with or without inflammation, using pharmacological iron therapy is you need pharmacological doses of iron. An iron combined with a multivitamin usually is not adequate, at least when you're correcting iron deficiency in the early stages. Also correct for ongoing blood losses. You can't correct unless you evaluate, so evaluate as well. And optimize diet, because as I've been treating more and more patients with iron deficiency, I've realized that uh, that there are a lot of our patients whose diet is not optimal. I was used to telling patients in my fellowship and early in my training is like, if you have a normal American diet, you should not be iron deficient, but that is not true. We in our clinic, we actually work with a dietitian and I'm surprised by the number of patients that do have an inadequate iron consumption. Also, another important take-home point that I've realized that since practicing, always monitor for recurrence of iron deficiency. A lot of these patients are going to be your patients for a while. And again, once you treat the iron deficiency, it's possible that if their underlying condition has flares, if they have episodes where they're having increased blood loss, they may have their iron deficiency may recur again. Always questions that come up is questions about transfusion. So I thought I'd throw a couple of slides in. One, trying to define an asymptomatic patient is always a challenge. I think everybody agrees that if the patient has cardiorespiratory compromise, your auscultating crackles on examination, patient needs oxygen, and also on auscultation, you're able to hear a third heart sound, then the patient is definitely symptomatic. Isolated tachycardia by itself is usually not a reason to transfuse. The other question that commonly comes up is what is a safe hemoglobin? And again, this again has not been well defined. We generally believe that a hemoglobin of less than 5, especially for patients, regardless of how long they've had the iron deficiency, they've had their anemia, is not safe. Some patients who have increased metabolism may be a little higher. 7 or below may not be safe, and those may be the patients that you need to think about transfusions. The ASH asked for choosing wisely recommendation, this I think was from a few years ago, suggested to avoid packed red blood cell transfusions for asymptomatic children with iron deficiency anemia and no active bleeding. The second point that they chose to highlight, which I think is important, is transfusion with PRBCs does not ensure complete treatment of iron deficiency, because the form of iron obtained from transfused PRBCs is not immediately bioavailable for erythropoiesis and does not replenish iron stores. So if you transfuse a patient for iron deficiency, you also make sure you need to treat the iron deficiency. Dosing has been traditionally empirical. Recent studies have shown that a dose of oral iron can elevate serum hepcidin levels for up to 24 hours. So most of us have moved away from twice daily or 3 times a day iron dosing, because the first dose in the morning or in the evening is going to elevate your hepcidin to levels that subsequently inhibit subsequent dosing. Alternate day dosing results in greater total iron absorption. This has been shown in adults, not yet in children. And it also definitely improves tolerability. So if your hemoglobin is in the safe range and your patient is having too many problems with once a day dosing, it may be worthwhile to consider alternate day dosing. Low dose once daily regimens, 3 mg per kg per day, or 1 tablet of whatever iron preparation you use most of the time should be enough. The common oral irons that we use are the ferrous sulfate and iron polysaccharide. Ferrous sulfate is available in the divalent form, absorbed much better than your ferric forms. It has a much higher incidence of GI side effects, and this could worsen your symptoms for your patients that have inflammatory bowel disease or pre-existing GI conditions. Only 20% is in the elemental form. So when you're dosing, you need to keep that in mind when you're writing out your dose. Iron polysaccharide is something we more commonly use. It is present in the trivalent form. It has a lesser incidence of GI side effects and may improve compliance. And 100% of iron is in the elemental form. So what your dose, what you write, is pretty much what is there on the label. When do you think of IV iron? I think we as hematologists have moved from. This is how someone who was at the ASH Symposium, I forget the name of the presenter, had said. Decades ago, we used to treat IV iron like cyclophosphamide, and now we treat it pretty much like an alternative to oral iron. You think about IV iron when your patient fails to respond to oral iron therapy, chronic kidney disease, inflammatory bowel disease, shortcut patients who are TPN dependent, and for patients who have iron refractory, iron deficiency anemia. So we have gotten more comfortable using IV iron regularly in our patients. Insurers have also gotten more liberal in approving IV iron preparations, I feel. It's always good to calculate how much an iron deficit is. There is this formula called the Ganzoni formula that every time I look it up on MD-Calc, but it basically gives you an iron deficit for your patient, and then based on the preparation you are using, you can decide how many doses you need to give your patient. The choice of the type of iron preparation is almost always based on what the formulary and what your payer decides to allow, and that keeps changing all the time. So know what's on your formulary and learn how to use it. How do we monitor for response? We generally think about hemoglobin to increase by 2 grams per deciliter within a month, but when you have inflammation, that increase may be slower. Also, along with hemoglobin, we also monitor another good indicator is your retic hemoglobin equivalent that I had talked about earlier, the 26 or 29 picogram number. That number, if it keeps going up over time, that's a good indicator that your patient is responding to iron. We may need to monitor those with ongoing bleeding more closely. Excuse me. At least 3 months of therapy is needed when you're using oral iron. It's possible that some of your patients may need more. A lot of times when we traditionally treat patients with just iron deficiency anemia, we say 3 months and you're good, but that is not always the case. Only about a third of patients who use ferrous sulfate are actually iron replete. So you might have to treat them for longer. Always assess your iron stores at the end of treatment. and also monitor for iron recurrence of iron deficiency anemia. So in conclusion, most iron deficiency anemias are attributable to a secondary cause and are treatable. There's no single lab value that independently predicts your iron deficiency. We always need to use our lab values in combination. Lower dose of iron therapy is effective to treat most iron deficiencies. With higher doses, you don't get much additional advantage. You get more GI side effects. IV iron is a useful second-line therapy for patients who fail oral iron or those who are unlikely to tolerate oral iron. And always follow the iron deficiency to the end. End of treatment labs may direct treatment for more than 3 months. And for pediatricians, AAP has supposed to be bringing out some guidelines. For almost 2 years, I keep looking up every time I talk about iron deficiency, but I think it's going to come out soon. So watch out for those guidelines, which I think are going to be very different from the previous guidelines, which I think are from 2010 or 2013. And with that, I'd like to thank you and looking forward to meet all those who will be in Chicago tomorrow.
Thank you so much, Dr. Jasudas. We really appreciate you. I think
Thank
right
you.
now, sorry, go ahead.
Sorry, I just said thank you for having me.
We have a 15-minute break built in right now. And so we will give everybody a moment to go grab another cup of coffee, go to the bathroom, and we'll see you back right at about 10:30.
Evelyn, are you still on? Or Chris?
Okay. What do you need from?
I was hoping I'm the next up, I think, presenting on
Yeah.
ANA. And I'm just a little worried that my slides are gonna have issues uploading. If I figure this might be a good time to troubleshoot before
Yeah,
everybody.
sure. Of course.
Okay. And then have presenters been having their video on or mostly having them off?
It doesn't matter either way.
Okay, so how do I get this up?
It didn't allow me to show my video, so I thought you'd.
Yeah.
Yeah, okay.
So are people mostly sharing screen? Is that what people are doing?
Yes.
Yes.
Oh, so I don't need to talk. It says so you don't need to talk online. I don't know. Okay. How's that look?
Perfect. I can see it.
And you don't see, if I scroll down, you're not seeing, see, I think it's, why is it being weird? Is it still showing just my first slide?
Yes.
Zoom slideshow, once again. It's not letting me go forward in the slides.
Hmm. Hmm.
Oh, there we go.
Oh, there you go. Yep.
Okay. Thanks. I just wanted to double check.
No, anytime. I think you said it, last name is Dreest, correct?
Yes, yep. Mhm.
Dreest, okay, awesome.
We moved to OneDrive, and there's been a few video where they've the PowerPoints have gotten messed up or they won't load. So I was just a little bit nervous.
Okay, welcome back, everyone. I'd like to introduce Dr. Kyla Dreest. She's a pediatric rheumatologist at Nationwide Children's Hospital and The Ohio State University. She has a master's degree in medical education from the University of Cincinnati and is a fellowship program director for rheumatology. She is the rheumatology representative to the hemato-immunolymphoproliferative and neuroimmunology clinics. Thank you so much, Dr. Dreest. And you may begin. Dr. Dreest, are you there?
Sorry, I couldn't unmute myself. I'm sorry. I knew I'd have some sort of technical problems. Thank you for that introduction. So yes, I'm Kyla Dreest. Today, I'm going to be talking to you about the ANA. So my talk is Your Guide to Interpreting the ANA, or why rheumatologists have a love-hate relationship with the ANA. And then I have no disclosures. So objectives, going over what the ANA is, understanding how to interpret it, understanding the utility of the ANA, and assessing the most opportune scenarios to order the ANA. And this is a little screenshot from Dr. Glaucoma Flecken. If you've ever seen his videos, he has a really good one on rheumatology. So what is the ANA? So it's the anti-nuclear antibody. There's two ways it's done. Generally speaking, it's done during the indirect immunofluorescence, but it also can be done via ELISA. The HEP2 immunofluorescence still remains gold standard, and HEP2 looks at laryngeal tumor cells that have like larger nuclei, so you can see the staining and the patterns more easily. The downside of immunofluorescence is it is time consuming, it's labor intensive, and so there is, some people are moving a little bit more to the ELISA just out of ease of practice. Still, the HEP2 remains the gold standard, but there is some data coming out that the ELISA may have similar sensitivity and specificity to HEP2 immunofluorescence. Data is still a little mixed, it's still a little early, so we'll see what time shows over the next few years. And this is just goes over sort of the patterns and what people might see if they're looking under the microscope. So in this case, the A is homogeneous, B is speckled, C is nucleolar, D is nuclear dots, and the E is rim-like. I will say in today's day and age, we put a little less stock in the patterns. We have so many more specific antibodies that we can test for that we are usually reaching for those and not putting quite as much stock into the actual pattern that they represent. The ANA titer is really important. And so what they're doing with that is diluting the sample until you can't see that immunofluorescence anymore. Some labs report down to 1 to 20. I know our lab reports 1 to 40 is positive, and some will set that threshold at 1 to 80. There are different ideas of where that cutoff really should be and what's considered normal. The EULAR ACR, and I'm going to go into the lupus criteria a little bit later, establishes 1 to 80 as an entry-level criterion. So they would argue that anything less than that is probably not that important. And many studies looking at healthy populations would set that at 1 to 160 and say that many patients at 1 to 160 And then below probably don't have any sort of rheumatologic disease. And the ANA is positive in a really wide variety of diseases and just healthy population. So I think everybody usually thinks about rheumatologic diseases as first line. It's probably the most common reason that we have referrals, at least in my practice. We have lots and lots of ANA positive patients coming our way. But, you know, a lot of healthy kids will have that as well. Thyroid disease is another big one. So 50% of patients who have Hashimoto's thyroiditis will have a positive ANA. And then I did even find a study with this quoting as high as 80% positivity in patients with Graves' disease. So, you know, if you're getting an ANA in a patient with thyroid disease, it's you know, flip of a coin if it's going to be positive or negative. Autoimmune hepatitis has a pretty high positivity rate of 60 to 90%. There is some data on non-alcoholic fatty liver disease, which was interesting. It's not super high above the cutoff for what you would expect in the general population, but maybe a little higher rate of ANA positivity in that population. And there is some reports of higher steatosis scores in those that do have a positive ANA. I don't think we really know what that means yet. There was some discussion over whether ANA is higher in patients who are obese, and maybe you're seeing a comorbid conditions there. But I think we still need to learn more about that. Medications have been associated with ANA positivity, malignancy, infections, so EBV, tuberculosis, Hep C, a number of others, and then just the healthy population. And I'll go a little bit more into that. And this looks at the ANA versus rheumatic conditions, and you can see sort of across the board the sensitivity versus the specificity, and I think that's a really important to look at. So for lupus, it depends on what criteria you use, but somewhere around 93% sensitive for picking up patients with lupus. So if you get a positive ANA, you know, you're going to cast a broad net, but you're probably going to catch pretty much all the patients who do have lupus. But the specificity is pretty low, so only 57% for specificity. Sjogren's syndrome, you know, we're going to see a similar trends of 48 and 52. Systemic scleroderma, pretty high sensitivity at 85, but the specificity is only 54. When you look at myositis, you've got 61, 63, and Raynaud's 64, 41. I do want to just compare that, though, to the double-stranded DNA and the anti-Smith antibodies. So in those patients, the sensitivity is lower, but you're getting a much higher specificity. So I'd say in these patients, I'm going to care much more if they have a positive double-stranded DNA than an anti-Smith, especially over an isolated ANA. ANA by itself doesn't usually mean a whole lot to me. And the ANA in healthy populations is quoted somewhere between 10 to 30% of patients. Really depends on which study you read, and it increases with age. So probably a little closer to 10% in your younger kids and 30% as you get into the older elderly age group. There is some reports that the ANA may be increasing over time, and we may have a higher percentage of our population that's ANA positive, but I don't think we really know what that means yet. And it's small amounts, but it does seem to maybe be creeping up over time. The majority of patients, though, that have a positive ANA and no rheumatologic diagnosis of presentation continue to do well on long-term follow-up. And I think that's a really important point to have. There is a study, Cabral and colleagues out of British Columbia. They followed 24 kids over a mean of 38 months, and none of those patients went on to have a rheumatologic diagnosis. And then there was another study, Deanne and colleagues out of Rochester, New York, and they followed 41 patients over 37 months. And the only one patient went on to have an autoimmune disease. That was autoimmune hepatitis. And what's interesting, that patient actually had leukopenia at presentation. So they had other labs that were abnormal, and it really wasn't just the ANA by itself. There was something else to say that this kid might be a little bit different. And the cost of the ANA is really important. So, you know, I talk about it's not really just the cost of the test itself, it's other costs that are associated and sort of that emotional, mental cost as well. So frequently the ANA is used, frequently the ANA is used as sort of a decision tree to tell whether somebody needs a referral to rheumatology or not. And So we get a lot of referrals that way. Anytime you're referred to a specialist, you're going to have additional costs associated with that, often a couple $100 just for the cost of the visit. And then any additional testing that's done is going to add to that cost. And I did find these values. This is off of LabCorp. Everybody's hospital is a little different. Some hospitals are it's going to cost a little bit more. Obviously, if you have insurance, some of that's going to depend, right? If you have insurance, good coverage. The ANA itself, though, is $50 or so. So the ANA itself isn't terribly expensive. But then you start adding to it, right? So if they go to a rheumatologist and they get additional testing, depends on how far they go. So if you get a double-stranded DNA, that's another $50 or so. If you order the ENA panels, the SSA, SSB, the Smith and RNP, you're looking at about $100 a piece. Complement, about $89. Anticardiolipin was quoted at $117. And the lupus anticoagulant workup with the mixing studies was at $400. And if you add all of this up, you're looking at a cost of $908 without even factoring in the cost of the referral itself in that visit. One of the other tests I did find the quote for is the ANA multiplex with the reflex screen, where they test an additional 11 antibodies, and that has a cost up to $1,370. So just something to think about as you're ordering the ANA is, what do you plan to do on it, and what do you think is going on? Is it worth that next step? Additionally, there's a lot of patient and family anxiety associated with this positive ANA. And some of it depends on how it's quoted to the families. I have families that are told that the lupus test is positive. I've had families that are just told that they have lupus or JIA off a positive ANA. And then I have some families that even if they're not told any of those things, they are told the ANA is positive, they get on Google, and the first thing they find is lupus. And they have been reading about lupus for the last month by the time they come to see me, and I will walk into that room and I have an idea of what they're looking for based off of, how many people are in the room. Sometimes I walk in the room and it's the grandparents and the aunts and the uncles, and there's a whole crew. And then I have to, spend a fair amount of time reassuring them. Additionally, right, there's unnecessary needle pokes, especially if you've got young children, needle phobia. So those are all things to think about. So which patients should have an ANA ordered? So if you have concern for juvenile idiopathic arthritis or JIA, those are definitely patients that you should consider an ANA in. And by concern for JIA, I think, joint swelling or limitation. Pain by itself is usually not going to be JIA. We see a lot of patients who have hypermobility, flat feet, fibromyalgia, and those patients won't have the swelling so much, but they'll have the pain. The ANA is not a diagnostic test for JIA. So if you're using the ANA as a decision tree on who goes to rheumatology, you're going to actually miss kids too, because a good chunk of kids with JIA will be negative for these antibodies. So they'll be negative for ANA and rheumatoid factor, but doesn't mean they still don't have arthritis and need treatment. On the flip side, of course, if you have sending all these ANA positive kids and you've got 20% of your population positive, you're going to over-refer a fair amount. What we care about with the ANA and JIA is that patients with JIA and a positive ANA have an increased risk of uveitis, and they're going to need to have their eye screened more frequently. So patients like a young child, oligoarticular JIA, meaning just a couple joints inflamed, and a positive ANA is going to need their eye screened every 3 months. So it's definitely important to know what that risk is. And then for Raynaud's, I did see you guys had a talk, but I wasn't there for it. I do think an ANA is a reasonable test in Raynaud's. Now, Raynaud's phenomenon happens in like 20% of healthy women. For a lot of people, it's an annoyance. It doesn't have to be a sign of autoimmune disease. When you have a positive ANA, you have a higher chance of developing some other autoimmune condition, like lupus, and I do tend to follow those patients and think about them a little bit more carefully. What I mean by true Raynaud's, though, so I have 2 pictures here. The top picture is Raynaud's. So you have what I say is a line of demarcation. So you could take a pen, draw a line, and say this is one color, that's another. It usually just involves the fingers or the toes. You have that pale color, usually set off by cold or stress. The picture below, though, is acrocyanosis, and you can see a very different picture. It's a more gradual color change. There's not that line of demarcation. It goes past the fingers. You're getting that ruddy purpley color rather than the paleness. And I wouldn't necessarily order an ANA with acrocyanosis. And then, of course, you should consider an ANA if you really think this patient has lupus. And I will go into that a little bit more. The lupus criteria. So I like to start with the 1997 ACR criteria. Lupus criteria, I feel like every couple of years now, we're coming out with a different set. But this is a good place to start and to just be thinking about who maybe I should be worried about. So to make diagnosis, 4 out of 11 criteria. The malar rash, and so this picture down at the bottom is somebody with a malar rash. I always talk patients who have darker skin may have a little bit more hyperpigmentation and a little less of the erythema. But you can see in her, there's a rash along the cheeks. It spares that nasolabial fold. Discoid rash is going to be more of a circular heaped up rash that can leave a scar. And then oftentimes you'll see that photosensitivity or the sun exposure setting things off, and that's particularly true with like malar rash. One thing I like to talk about, I grew up in Florida, but I live in Ohio, and Ohioans don't seem to know what it means to be overheated. And so I've gotten referrals for patients who went out in the sun, they got red cheeks, they went inside, they cooled down, cheeks went back to normal, but they took a picture, they told their pediatrician about it, and they got a referral for malar rash. So generally speaking, lupus, these are things that are going to stick around for weeks. Nothing is like coming and going so rapidly. Mucocutaneous ulcers, so nasal ulcers, palatal ulcers. So it's a good one to look for. So looking at the roof of the mouth, patients, they're often painless. And so patients may not bring that to your attention. So you really have to look for it. Inflammatory arthritis, serositis, so pericardial or pleural effusion. And then lupus nephritis is a big one. So looking for hypertension, edema, protein in the urine. They're going to end up getting a biopsy if we're concerned about that. Neurologic disorders, so usually seizures and psychosis are the big ones. And these kids are usually very sick, oftentimes in the hospital. Hematologic disorders, so any cell line can be affected, but I always say that it needs to be better explained by autoimmune destruction than by something else. So like iron deficiency anemia would not count. And then you get into your lab tests. So immunologic disorders, so double-stranded DNA, your Smith, your antiphospholipids, positive ANA. So when you're thinking about whether to order an ANA and you're thinking, could this be lupus? I always say it's good to go back to sort of this list and say, well, are there anything on this list that I can check off? And if you can't, then the likelihood that this is lupus goes down significantly. And these are the EULAR ACR criteria from 2019. They went to sort of a point-based system. So instead of just like checking off and having a certain number, everything has certain weights to it. But the different diagnoses are fairly similar. What's interesting, though, is that the ANA becomes an entry-level criterion on this study. So at 1 to 80, if you don't have an ANA of 1 to 80, you don't even enter into this criterion list. Generally speaking, around 10 is going to get you a score to say that this looks like lupus, and weighted things more heavily like renal disease. If you have class 3, 4 lupus on biopsy, that gets you 10 points by itself. And one of the sections there really is the hematologic manifestations. So I do think ANA positivity in patients with like hemolytic anemia or ITP is a reasonable thing to check. Now, ITP in, a 2-year-old or something, maybe less so, but your teenagers, your adults, it's definitely something to think about what their risk is. 5% of patients with lupus will present with ITP as their first manifestation. So these patients do exist. And they do have the highest risk of developing lupus in that first 4 years after diagnosis. They have done some studies following patients who have a positive ANA and ITP, and they found that patients who did have a positive ANA had a lower platelet count at diagnosis. They also had a greater proportion of patients who had a positive ANA that needed significant immunosuppression, things like rituximab. Patients who were ANA positive had a longer duration of symptoms and more refractory course. And when they followed those patients long-term, 15% of those that were ANA positive went on to have a connective tissue disease like lupus. versus 2% in the ANA negative group. So it did have a little bit of predictive value. It definitely gives you an idea of somebody that you may want to follow a little closer. And then when you look at those autoantibody panels, so these are those panels that come back and they have, 10, 11 different antibodies, the histone, the Jo1, the SSA, and they have just a whole list that are tested. There was an endeavor a few years back called Choosing Wisely, where they were trying to reduce the cost of medicine. And one of the big focuses was on ANA and these autoantibody panels. One of the recommendations that they had was doing it in a stepwise fashion, so not doing the panel unless the ANA was positive. I will say if you have a kid who is in the hospital, they have, amelar rash, a discoid rash, inflammatory arthritis, just get it all. Especially the way ours is run, a lot of our tests are only done once or twice a week, and we're going to want to have those answers. But if you have somebody that isn't so cut and dry, doing it in a stepwise fashion is a better way to go. And really, ideally, would be doing targeted testing rather than a big panel. So, they have a lot of antibodies on there, SCL70 looking at scleroderma, Jo1, histone antibody, and some of these are not really maybe relevant to your patient. I tell the example, I had a child who was sent to me with a positive histone antibody off of one of these panels, and the kid wasn't on any medications. So didn't have drug-induced lupus, hadn't been on any medications, was completely healthy. So why that antihistone would not have been chosen, but it came back up on this panel. You can get false positives on these panels. And then I would be wary of these arthritis panels. I think they're gaining a little bit of ground. Example of that, my dad had osteoarthritis, and his primary doctor was writing arthritis panels, and he had them done a couple of years in a row, looking at rheumatoid factor and ANA. But my dad didn't have inflammatory arthritis. Of course, he did end up with a positive ANA, and he got referred to rheumatology, and I'm sure that rheumatologist laughed at the referral. But next year, they ordered the arthritis panel again. So just be wary of them really choosing who you're ordering these panels in. And when to avoid ordering the ANA. So vague complaints without a lot of clinical findings. So that patient who comes in, who is achy a little bit, who's tired, when they've done studies looking at those kinds of clinical pictures, the positive predictive value of the ANA is almost 0. So really not a great population to do it in. Similarly, widespread pain. So often thinking of fibromyalgia, amplified pain patients, the positive predictive value of ANA is about 0. I also resist ordering the ANA if I can in these family history of autoimmunity. So an example would be somebody who mom has lupus. They're really worried their child's going to have lupus too. They just want them to get an ANA so they know what their risk is going to be. If you're looking for reassurance, you probably are not going to get it. I find that, they do have a little higher risk of being ANA positive just because they have a family history of lupus. And that doesn't necessarily mean they will go on to have lupus themselves. What I prefer to do in patients like this, rather than ordering the ANA, which may not mean a lot and may become sort of an anchor for the patients to focus on, I order around the ANA. So if you're thinking of this checklist here, right? So if I order a urinalysis, right? If I have proteinuria, that's something to think about. I order a CBC. If they have hemolytic anemia, they have low platelet counts, then maybe they deserve more workup. Similarly, complement, I will order a C3, but not a C4 usually. A lot of people have null alleles to C4, and they'll have just instead of having like 4 copies of the gene, they have like 2, and their C4 is always a little low. I don't put a lot of stock in that if the C3 is normal. So in these patients where I have a low suspicion, I just pick out the chests that I think are going to be the most helpful in evaluating further. And looking at these ANAs too, and whether you repeat them over time. I've had a few interesting referrals where I've had patients who've had their ANA checked like every year for 11 years. There is no utility in following these titers over time. So even in my lupus patients, if the ANA comes back positive and I diagnose them with lupus, I don't recheck the ANA. Now, the cryptidia or the double-stranded DNA is a different story. That can fluctuate with disease activity, but the ANA really doesn't have that value. And when you follow patients who were initially negative, and follow them over time, usually you are not going to change the diagnosis with repeat testing. So really, I think it's best to really base your testing off of clinical symptoms. So let's say a patient got an ANA drawn 2 years ago for fatigue. Not ideal, but they got it done for fatigue. It was negative back then. Now, 2 years later, they come in and they have inflammatory arthritis and a malar rash. That's a different child than the one that presented 2 years ago, and you should absolutely get an ANA at that point. But if they're presenting with similar complaints, they don't have anything new and concerning, I would not repeat that ANA. And so take-home points. So the ANA is positive in 10 to 30% of the healthy population. Positive ANA does not necessarily mean that it's a sign of impending autoimmune disease. And really, the ANA should be reserved for patients with a high positive predictive value. Similarly, repeat ANA testing, use it sparingly, and then only really in patients where there's been a change in clinical status. And these are my references, and that's it. So thank you very much. I know we have a panel a little bit later where we'll chat some more.
Thanks, Dr. Dreest. Really appreciate it. That was an excellent talk. Dr. Lopez, are you ready to for your talk to start?
I am.
Perfect. I just want to give you, Dr. Lopez is a pediatric allergist and immunologist at UH Rainbow and Babies Children's Hospital and Case Western University in Cleveland, Ohio. And he's the director of the Inborn Errors of Immunity Clinic there. Thank you, Dr. Lopez.
I was trying to set up my camera as well, Chris, but it says that I can't because Dios disabled it, but I can still talk through it.
Okay.
Do you guys see like the real screen or the smaller view? Does it look good?
There we go. That looks good.
Okay, perfect. Okay, so thank you very much for the invitation. So we're gonna try to talk for the next 20 to 30 minutes or so about angioedema and a few mimics of angioedema. So kind of like several of the reasons that in the real world you have patients coming in with swelling and things in that range. So I have no disclosures relevant to this talk. The goals will be to recognize differential diagnosis of angioedema, as I was briefly talking about. We'll identify the differences between angioedema, which is the main division, as we'll talk about in more detail, mediated by histamine or mediated by bradykinin, and then recognize different management options for different types of angioedema based on the clinical history and the labs and all those things that we'll talk about as well. So angioedema, it's quite a broad term because you tend to think about it in terms of swelling that you can see in patients, and you know the differential is wide even outside of these two main types that we'll talk about during the talk today. But you think about it with clinical situations like these ones over here. If you see like massive lip swelling in a patient, regardless of the age, it can translate in things like throat symptoms as well due to glottic, that can be as severe as glottic closure and be life-threatening in that setting as well. The type of angioedema kind of like changes around some of the presentations from a body part standpoint, and we'll talk through those as well. So as I mentioned in the beginning, the main initial division when you think about angioedema, and this says a lot of implications not only in the way as you approach it, but also in the way as you manage those, has to do with this big division between two types of angioedema. So the first type is the histaminergic angioedema, that you tend to think more about quote-unquote allergic angioedema, even though that term may be a little bit broad, but this is the angioedema / swelling that you see in the typical IgE-mediated type 1 hypersensitivity allergic reactions when somebody's allergic to a food, to a medication, to venom. And it's also the same mechanism that leads to angioedema in the setting of chronic or idiopathic angioedema, which is a condition that most frequently comes associated with chronic urticaria as well and hives, and we'll go into more detail in that in a second. And then you have a different type of angioedema that is mediated by bradykinin, and this is the category where the most recognized type of condition is hereditary angioedema, and autosomal dominant genetic condition that we'll talk in more detail as well. But then you also have, as you all have dealt with in clinical practice for sure, things like ACE inhibitor-associated angioedema or acquired angioedema. They are not necessarily hereditary conditions, but the pathophysiology also involves dysregulation of bradykinin production or degradation. So how to differentiate is one of the most crucial aspects, right? So frequently, the histaminergic type is associated, it's not always, so keep that in mind, but very frequently is associated with other signs and symptoms of this type of IgE-mediated reaction that we're talking about, such as urticaria, pruritus, flushing, bronchospasm, or even hypotension if you go into like an anaphylaxis type of presentation. So you do not tend to see these features so much in bradykinin-mediated angioedema. The other thing for histaminergic angioedema is that it frequently has a clear trigger for the allergic causes that we were talking about as well, that kind of like leads you to a timeline to suspect it. Or if you know there's a personal medical history involving it, right? Somebody's allergic to peanut, they ingested something, they're not sure if it has peanut or not, but they start getting very swollen, there's a good chance that could have been cross-reactivity with peanut or anything in that range. The bradykinin-mediated, as we were saying, not so much associated with these typical allergy symptoms or triggers. The time course is frequently more prolonged, even though this one here is not mandatory because it depends on exposure, but as you'll see, several of those tend to lead to courses that last at least for several days. And the association with the trigger is frequently not clear, which is by itself not a reason for you to think about bradykinin-mediated, but it puts it higher in your differential for the type of angioedema you're dealing with. So in terms of the histaminergic, as we already said before, from a clinical pearl standpoint, it really frequently pairs with other signs and symptoms such as urticaria, pruritus, flushing, bronchospasm, even hypotension if you are in this anaphylaxis type. So that's like the most important part of it as well. And the causes, as we talked about, are the several causes that can cause angioedema. So the diagnosis based on that tends to be mostly clinical. The fact that you have some of that global presentation that I was talking in the previous slide, paired with response to medications that we'll talk a bit more under the management, lead you to diagnose histaminergic angioedema from your office to the emergency department to the inpatient setting, mostly based on a collection of a good clinical history. You have some accessory labs that can be helpful. This is in no way, shape, or form mandatory, but there is a lab test called serum tryptase. Serum tryptase is one of the mediators inside the mast cells, your allergy cells, and once they degranulate in the setting of an allergic reaction, it's usually elevated in circulation for around like 20 to 30 minutes to up to 4 to 6 hours after the onset of symptoms. So the timing of collection is critical, but it may be helpful in some of the situations if it's very unclear in your differential what type of angioedema you're dealing with. Just keep in mind, not making this like a full talk about serum tryptase, but one of the issues with serum tryptase is that it takes several days to come back. So this is good in the long run, but it's not going to help you a lot of times in the acute phase unless you work in an hospital that turns you this over in a few hours. And the other thing to keep in mind is that sensitivity and specificity, like the test quality of serum tryptase, depends on the type of allergen. So for instance, if we're talking about an IV drug, you have a very, very high sensitivity. So a negative serum tryptase almost tells you that there was no mast cell involvement in that reaction, even if it looks like anaphylaxis, because sometimes you're dealing with infusion reactions and others. While for things like food is a little bit trickier because you're talking about the range of 40%. So if you have a positive serum tryptase after somebody has angioedema after they ingested something that they think they may be allergic to, it will reinforce that. But if it's negative, it's far from ruling out that the food was the cause of that type of swelling. So it's a test that it's helpful, but needs to be managed with a careful approach, depending on the test quality as well. So the pathogenesis of the histaminergic angioedema, as I've been reinforcing through the different slides, it's most commonly IgA-mediated hypersensitivity. So you have IgA antibodies that for some reason is sensitized to a drug, a venom, a food, that they live on the surface of your allergy cells due to that process of sensitization. And then if you have contact/ingestion, so contact would apply more for like local swelling that you could have, but more generalized systemic reactions would be more due to ingestion or intake. Whenever the body sees the allergen or has contact with the allergen, leads to the granulation of the mast cells, either locally if it's just contact or systemically if it's ingestion or intake. And then it releases all the different granules, tryptase, histamine, all the others, leading to the signs and symptoms that can go from local to systemic, depending on how the approach happens as well. Just keep in mind that this type of presentation is not always IgE-mediated hypersensitivity, and I'll tell you about a couple of examples that are kind of like way more common than people think and have practical value, I think. One of them is aspirin and NSAIDs. So a lot of people on aspirin and NSAIDs, regardless of having a baseline of developing hives or swelling more frequently, it happens more in those patients, but it can happen in patients who have no history of swelling or hives at all, may have a presentation with urticaria and or swellings, it can likely purely be angioedema, in the setting of taking aspirin and NSAIDs. And usually this is called an allergic reaction, and people think they're allergic to that specific medication. It's rarely the case from the traditional standpoint of allergy that we were talking about before. So it's pretty rare to have specific antibodies or specific sensitization to a particular NSAID. And usually when that happens, you're specifically allergic to that one, like you're specifically allergic to ibuprofen, and you have an allergic reaction when you take it, but you would not be to diclofenac. The process that happens here, it's what we call a pseudo-allergic reaction that will be like class related. So any aspirin or NSAID that your patient will take will lead to angioedema and or urticaria. And that happens because of pathophysiology and not necessarily because of an allergy. So what happens is that NSAIDs are COX inhibitors. And because they inhibit this pathway, you have an uptype, an increase in production of leukotrienes, which is the accessory pathway of metabolism for arachidonic acid. And leukotrienes are substances that that lead to all of these presentations in terms of leading to degranulation of your mast cells and can lead to swelling and hives and combined presentations as well. So we'll talk about that a little bit when we get to management as well and how to approach this, but keep this in mind because this is a very frequent finding in D&D and in clinical practice where people actually like, I mean, practically you still need to list them as allergic, but the way you manage them is a little bit different than if they were truly allergic to it as well. And then the other one that is very common for us to see and get inpatient consults on or outpatient consults on is opiate-related angioedema and or urticaria with combination of those. And this is not only applicable to opiates, but opiates are just used so much, probably too much, right? But in some patient populations, you don't have a big way around. So because we're an immunoheme group, just thinking about sickle cell patients that so frequently not need opiates for the control of their disease. And opiates, the large majority of them, they are able to non-specifically binds to a receptor called MRGPRX2 on the surface of mast cells. And this receptor, or the activation of this receptor, needs to activation of your mast cells, that it's not related with you having an Ig molecule on the surface or being allergic to the medication as well. So you can take opiates and suddenly you start swelling up and you start having hives and you think you're allergic to that opiate, and it's not necessarily the case. And the difference from if you were allergic, amongst other things, is that different classes of opiates may cause this and others not cause it, and additionally, it tends to be dependent on the dosages and kind of like the way that you get these medications, which would be different than if you were allergic to oxycodone, where it wouldn't matter at a certain point because you probably would react to it regardless. So it does have kind of like clinical implications similar to the prior one. You still need to avoid it or use an alternative one, but there is a difference in what you can do to it because of a different pathophysiology, and it's a very common finding in those patients as well. So the management, as we were saying, for like the typical Ig-mediated hypersensitivity causes, which is the main one, most importantly, second generation H1 blocking long-acting antihistamine medications like cetirizine, like levocetirizine. We see people recurring to those to help with those symptoms, but we see patients being underdosed all the time. So you can go up to as much as 4 times what usually would be the daily dosage of an over-the-counter antihistamine. And this is critical because these are medications that will lead to stabilizing the mast cell and reducing the level of degranulation. Then when you're up to something like 4 times a day of these medications and it's still not working, you can have H2 blocking antihistamines, which I put example famotidine, but it's pretty much the only one that is in the market right now since ranitidine was out of the market. And this is like an add-on to the first generation. Some patients are either refractory to all of these regimen that we're talking about, like 6 pills a day, or they're not, but they do not want to take 6 pills a day for a long timing. So you have a biologic medication approved, omalizumab, that is an anti-Ig antibody, that is a subcutaneous injection that is approved for several other indications, and patients can use these injections every 4 weeks. It's approved for 12 and above, and frequently used in this setting, and occasionally, not that rarely, we get it approved for younger kids because it has younger ages for other approvals, and it helps patients on the pediatric side with chronic spontaneous urticaria / angioedema as well. So angioedema is not like specifically an indication for omalizumab, which is something to keep in mind if you think about using it in that setting, but you can justify to insurance and explain the mechanism and the pathophysiology. And after the 4-hour peer-to-peer call, you may get it approved finally for your patient, and they'll feel better in that setting as well. In your rising, you have some other medications that can be more helpful, especially in some ages, and because it's an oral medication and not a subcutaneous medication, but there is an oral BTK inhibitor, remibrutinib, that is used in other indications that several of you may know of, and it had a successful phase 3 trial for chronic spontaneous urticaria. So it's not yet FDA approved for that indication, but it hopefully will be soon, and then it probably can pair out with chronic idiopathic angioedema or associated angioedema to that type of CSU presentation as well. What is not a best option for these patients are things like short-acting antihistamines. So the patients that are tanked on Benadryl or Atarax or any of those, it's not the preferred medications because they're very short-acting and there are plenty of side effects. Leukotriene receptor agonists like montelukast, this is terrible medication with a lot of side effects in general by comparison. So maybe like slightly helpful on to as a third line for all of this as well, but the benefit does not tend to outweigh the risks that in general you tend to get with that as well. So it's very rarely used in these settings. Not written here, but prednisone in the acute setting may help these patients. But if you treat somebody with a course of 4 or 5 days of prednisone, you need to like very slowly wean afterwards, because if you don't and you just treat them for 3 to 5 days with a high dose of steroids, they will tend to rebound considerably, and their symptoms may be much worse once they stop the course of prednisone / other steroid than it was in the beginning as well. And for the other two, as we were saying, like aspirin, NSAID, pseudoallergic reactions, in general, avoidance, those patients can take acetaminophen in general up to 650 milligrams per dose. The specificity on the dose here is because acetaminophen becomes a COX-1 inhibitor once you go above certain doses. So some patients may be fine, but then if they take like 1 gram of acetaminophen or things in that range, it may end up causing the similar symptoms. You can desensitize to aspirin and to NSAIDs, mostly to aspirin. This would be more frequent in somebody who had this type of condition, but they really needed it for rheumatological conditions or pain control or something like that. But if you do that, then you need to be on high dose aspirin every day. So unless the GI colleagues are bored and need to scope a lot of people, it's probably not the best solution these days, because that would probably lead to like a lot of GI side effects and all those things as well. And you also have as an option, even though it's more for adult populations, but highly selectively COX-2 inhibitors like celecoxib that have their own range of potential side effects, especially from a cardiovascular standpoint. But these are medications that do not tend to cause this when people have pseudoallergic reactions to aspirin and NSAIDs. And then for the opiate non-specific reactions, depending on the mast cell receptor, you can pre-medicate, and that a lot of times allows you to take the same oral or IV medication if you use the same cetirizines, famotidines that we're talking about for the IgA-mediated type, or choose an alternative opiate of a different class of opiates, because that tends to be helpful as well. Then moving to the next type, the angioedema or caused by dysfunction of the bradykinin pathway. So multiple pathways rely on C1 inhibitor. Everything that you see here with two marks are areas of the clotting cascade that are inhibited by C1 inhibitor. So even though there's a lot of hematologists in the room, I swear I won't go in detail through the clotting cascade that we all seem to remember for 5 minutes after studying it, and then recurrently forget after the tests. But you still remember this from back in the days, and some of you from still in the common day these days. So you see that C1 inhibitor is a pretty critical molecule in a lot of these pathways, both coagulation pathway, fibrinolysis pathway. So this function of C1 inhibitor, both from a quantity or quality standpoint, leads to, or associated molecules, leads to angioedema by proxy because of this as well. So you see, ultimately, what they all have in common when you have a dysfunction of this whole area is that you increase vascular permeability, and that leads to angioedema as well. And not that that was not reinforced before, but keep in mind, we're talking about a totally different pathophysiology and system from the other angioedema we're talking about. So you can give 5,000 kilograms of steroids to this patient, that is not going to change things from that range. So the approach will be different from a management standpoint as well. But these multiple pathways regulate the C1, that rely on C1 inhibitor, basically regulate the propagation of the biochemical reactions leading to the release of soluble bradykinin. And this is important as well when we talk about the medications that can be used in these settings. So the presentation, as I said before, it tends to be different. And now we're talking a little bit more specifically about hereditary angioedema, and then we'll talk about the other bradykinin types. But the attacks tend to be more prolonged. They involve extremities, abdomen, genitourinary tract, face or pharynx, larynx, combination of the above, a little bit more propensity to some of the extremity swelling presentations and global face ones that you sometimes see with the other type, but none of these are pathognomonic of the type of angioedema. Very common to have a family history of angioedema in up to 75% of patients, and this is a genetic disease, an autosomal dominant disease. So if you have a parent that has this condition, they have 50% chance of passing to each of their children. Why not 100%? Because sometimes it's about a new variant in a patient and not necessarily from something that they inherited from their parents. And most often begins during childhood. Not that the other type can't, but the other type can happen at any age. It's not very common, or it will not be very common for somebody with hereditary angioedema to have a very, very late presentation past the first, second decades of life. You need to keep in mind that there are some prodromal aspects that sometimes make this confounded with the other type of angioedema. The trickier one is this transient erythematous prodromal rash, because it's erythema marginatum. You see, if you look at this picture over here, that this does not look as urticarial as the other rashes do, but I think there's a global tendency to call everything hives or urticaria. It's a different rash, but sometimes it leads to confounding diagnosis and treat it the other way as well. This one is usually more associated with localized tingling and sense of skin tightness, but the patients can have other things like fatigue, malaise, flu-like symptoms, irritability. So you see when you talk to patients with HAE that they tend to know when an attack is coming very frequently. Up to 50% of the patients at some point before an attack develop those symptoms as well, and that kind of like gets you a clinical gist of what could be going on as well. Then the classification for bradykinin-mediated angioedema. And these are the two separate ones that I told you we'll talk about briefly after HAE, after hereditary angioedema with the secondary to AC inhibitors and the acquired angioedema. But the hereditary angioedema, basically it has kind of like three categories of division. C1 esterase deficiency is the main one, and here your main division, classical division, tends to be related with variants in the gene SERPING1, are either hereditary angioedema type 1, that is due to low levels impaired production of C1 inhibitor, or a type 2, where you have normal numbers, but the function is lower. This on the right side is an area with a lot of growth and still with a lot of unknowns, but there are a lot of patients or a good amount of patients with hereditary angioedema that have normal quantity and function of C1 inhibitors. And those, now that we know more about genetics, tend to kind of like get a new division depending on where their gene variants fall that lead to this as well. But they're sometimes a little bit trickier to identify just because of the lack of clinically available functional tests to lead you to those. But if the history is there and you feel like it, and C1 inhibitor is normal in quantity and function, then you can get to a genetic level and some deeper down from a functional standpoint that is then at some labs to try to understand a little bit better if you can have one of those variants as well. The diagnostic, this test is also like board material for a lot of specialties, including immunology and hematology, but you'll see it in the real world as well. It's not always, because you see in some of them there's like slightly differences, but it gives you a good idea of what you can do. Keep in mind, you don't need to order these tests on every single patient because sometimes you may have enough. So it's a common pattern depending on which institution or physician you talk to. But if you're not truly sure if this looks like hereditary angioedema or not, something like sending a C4 in itself can screen you for the more common type 1 and type 2 type of functions. But then you see you have a huge variation of these labs as well. And there are things like C1q that become relevant only in the setting of acquired angioedema. And there are some clinical settings that you think more about this as well. But it's not totally unreasonable if this is in the setting of you seeing patients with hereditary angioedema relatively frequently and having that in mind, to even send a level and a function and add that to the C4 as well, as long as you think it's in your realm of interpretation to do as well. Then the management It's variable. So for HAE, for hereditary angioedema, the treatment depends on what you're talking about. We'll have a few slides kind of like show you through the differences, but you basically have a triple type of approach to these patients. They need to have, and that's the only one that is like definitely mandatory, they need to have a medication that they can use for acute attacks, either something they can do at home or something that they can do in the setting of an emergency department if they can quickly go there or call EMT to do it. Prophylaxis is not mandatory, but it's probably recommended for the majority of the patients, and it depends on the number of attacks they have per year. But it is A and age, if you can approve them for prophylaxis, it tends to be something you do. And you divide this in short-term prophylaxis, and this is more what you would do before the patients go for a surgery or even minor procedures that may stress their body and lead to an HAE attack. And long-term prophylaxis are medications that are independent of that. So just medications that you try to use to keep the patients away from having acute attacks or to reduce the frequency of acute attacks as well. So as in the prior one, this one looks prettier, but I swear I won't like crush your morning by going in detail on complement contact activation system and coagulation system charts and figures. But this is just to give you an idea that a lot of the medications, and I'll have on the next few slides, we'll go over those, have been developed with an approach that kind of like goes all over the place over here and tries to correct the errors or go after what happens, and it's dependent on the type of pathway that is involved. But a lot of work has been done to kind of like act upon the different places in this pathway. So for management of acute attacks, these days you actually have quite a few options, and this improved a lot. And let's keep in mind, you have quite a few options where they are available, because a lot of what I'm showing you over here, it's incredibly difficult to find in countries without a higher amount of resources. But in terms of US, North America, you have the most traditional form that would be like C1 inhibitor concentrate that is plasma derived. So if you think about it, if you have a lack of C1 inhibitor or lack of function of C1 inhibitor, correcting it's the more logical one as well, but it requires IV. Then you have recombinant C1 inhibitor forms that kind of like do the same job, except that they're not derived from plasmas. They're prepared in the lab. Now you have, in a lot of patients, like medications like this, sub-Q acute attack on-demand medications like bradykinin B2 receptor antagonists like icatibant and kallikrein inhibitors like ecallantide. But it's always, like for several other things that we do in medicine, share decision-making about the pros, the cons, what works better for the patient, their age, etc. That leads to the selection of these medications as well. Because as in a lot of these areas in medicine as well, you don't tend to, not for everything, but you don't tend to have like great like side-to-side studies for some of these medications in the setting of that. And then ultimately plasma, if nothing else is available, and like saying that in high resource settings like the ones we have in the United States, we wouldn't need to recur to that, but unfortunately that's not true. Like I'm in Cleveland, if you go 15, 20 miles outside of the city, unfortunately, I have a lot of emergency departments that don't have any of these products unless you know your patient is in that area. You call the ED, you have them get prepared so that they can use it at that time. If nothing else is available, you can use plasma, because plasma will have some C1 inhibitor. The problem is that it can lead to paradoxical worsening because it also has all of the other factors as well. So plasma can go either way. But if nothing else is available, and considering the life-threatening character of HAE, you may still need to treat patients that way as well. And then prophylaxis, similar, you still have a lot of options as well, similar to the on-demand acute attack medication C1 inhibitor, IV or sub-Q in this case, because you can use sub-Q for prophylaxis. And then you have two medications that have kind of like more recently come into circulation. By more recently, still like 4 or 5 years for some of them, but it kind of like changed the panorama of prophylaxis quite a lot as well. So monoclonal antibodies that bind kallikrein, which is lanadelumab, which is a sub-Q medications that patients can do at home. And for patients who are afraid of needles or have that as a preference, there is also now an oral plasma kallikrein inhibitor, berotralstat. More traditional medications that were used at the time would be things like androgens, but with a lot of side effects, and antifibrinolytics with their own set of side effects as well. But out of those two, tranexamic acid usually would be preferred to epsilon aminocaproic acid. In the real world in the United States, it's not used a lot as long as you can get approval for the other medications. But I know in a lot of places in the world, it's almost still first line or close to it for prophylaxis due to the cost. So the bradykinin-mediated aspect of the ACE inhibitor, you can see it on this figure on the right, that ACE inhibitor blocks degradation of bradykinin because of its effect on ACE, and that ultimately is what may lead to increase in bradykinin, and that connects the bradykinin to receptor, and you have vasodilation. So this is up to almost 1% of the patients on ACE inhibitor, which is still pretty considerable because this is a very commonly used medication. Tends to be mostly frequent during the first month of therapy, but don't get sidetracked by that, because it can happen after many years of being on the same medication as well. There are a few risk factors that are known, such as history of smoking, increasing age, being a female, diabetes. Typically, they'll have angioedema to different ACE inhibitors, so you don't tend to play around with the different ACE inhibitor, and you may switch to an angiotensin receptor binding agent blocker, because those tend to be well tolerated as well. And acquired angioedema happens, it's still the same pathways, but acquired angioedema happens due to autoantibodies against the same C1 inhibitor pathway that leads to the deficiency because the molecules are blocked. The management is similar to hereditary angioedema because the problem is the same, but antifibrinolytic agents that are far from first line in the management, as I was telling you for HAE, have more efficacy in acquired angioedema, and by proxy there's decreased efficacy of C1 inhibitor replacement, so the management is done a little bit differently. And very critical in this one, especially in more advanced ages, but in any ages, is to evaluate what's going on and what's the underlying condition, because this usually doesn't come out of nowhere. So it's pretty frequent for this to be associated with B-cell malignancies mostly, especially in older ages, but even with connective tissue disease or other diseases that can lead to the production of autoantibodies against these pathways as well and lead to an acquired C1 inhibitor deficiency. And then finally, the other differential diagnosis is vast, but you can think about anything else. There's a lot of conditions that can lead to swelling of your tissues, like contact dermatitis, cellulitis, facial lymphedema from structural reasons, some autoimmune conditions, parasitic infections, hypothyroidism, SVC syndrome, even factitious angioedema that is more frequent than we would like, and they all need to be kept in perspective as mimics of these other types of angioedema, because the management and the treatments will be completely different as well. So take-home points, broad differential, two main categories as we talked about, usually easy to differentiate because on clinical presentation respond to medication. You saw the labs that can help you for either or. You don't need to send all the labs for all the types of angioedema. That's where the clinical acumen comes and helps see what you should use. And there's a large array of therapies to prevent angioedema and to treat echo attacks, both short and long term for all the types of angioedema that we talked about that as well. And with that, I thank you. And I think we'll go right into the Q&A, so I'll have time for questions for all of us. Thank you.
Thank you, Dr. Lopez. Yes, this time opens up. We'll probably spend the next 20 to 30 minutes for any questions you have to any of the speakers. And you can include, I'll try to read them off in the chat box too for any questions that come through. Dr. Dries, I had one question with the study that followed those kids that had isolated positive ANA who did not develop rheumatologic disease. Did that include kids of low titer and high titer in that study, or was there a cutoff?
They followed across the spectrum.
Okay.
And there are some studies that looked at like the spectrum and how likely they are, and if they didn't have any other symptoms, even at the high titers, they still had a less than 50% chance of going on to have an autoimmune disease. But you do have a higher risk of developing an autoimmune disease with higher titers. So you're correct there.
Thank you.
Dr. Phalein, I just had a quick question about those of us who are not rheumatologists. When would you, suggest referring patients for Raynaud phenotypes? Or I guess Dr. Dries as well could answer that.
Yeah, good question. Yeah, our threshold here, we kind of see everyone recover multiple states. So I think if there is anyone that has Raynaud's, we'll see them. That's just kind of our policy here, because I think it's important. There might be just little things like tiny clues that might get missed. So we do want to capture those kids that have secondary Raynaud's. We do have kids that are coming like 12, 13 hours away. We cover both Dakotas, my colleague and I. So if we have someone where they're from Rapid City, we sometimes will have them send pictures to us first, just to make sure that's truly Raynaud's and not acrocytosis, or something we can maybe probably just do a virtual visit for. So
yeah, at least half of what is referred to me as Raynaud's is acrocytosis. which is
Probably what we get to.
sometimes I can see it and I'm like, oh, that's what it is right there. Okay, we don't have to worry about this.
We like kids are like, oh, my hands are cold, and they're like, oh, you have Raynaud's, and they get referred to us, and so it.
And one nice thing, I don't know if Dr. Failing talked about it. Sometimes the acrocyanosis is dependent. So if they're dangling their feet and they're blue, and you pop them up on the table and they turn pink, it's like a beautiful test right in front of your eyes. So I like to do that, and it's also very reassuring to the family. We're like, oh, look, the color's coming back.
I had 2 kids last week. The girl's had it since she was like 2, and they've had every like vascular imaging. They see multiple things. Like did that exact test, and they're like, "Oh, this is wonderful. I don't need to be worried anymore."
There is a question in the chat box for Dr. Lopez. What are the costs for the C1 meds, and can families have these on hand to bring with them like we do for hemophilia factor replacement?
Hi, Melissa. Thank you for the question. That's very important and a great question. So the cost part is critical, and I think that's why I was saying that you have a lot of countries where these medications are not even available. For instance, for HAE, as we were talking about, and then we'll go to the second part of your question. But for prophylactic medications, both the sub-Q biologic and the oral inhibitor, real costs would be around $30,000 a month. So that's a lot of money. So unless you're Elon Musk or Bill Gates, probably wouldn't be able to carry that one on your own. So in general, it truly depends on insurance approval, because it's a rare disease, and because you don't have great alternatives that are cheaper unless you go to like more subpar medications that do not have the same clinical benefit. It's a big uphill with insurance fights, but they do tend to approve this for these patients. The on-demand medications for them to either use on themselves or take to the ED are slightly cheaper, which doesn't say it's cheap, but they're slightly cheaper depending on which ones you consider. They do it the same way as you're saying for your hemophilia patients. So depending on what they want, if it's like a sub-Q, it's even easier, because as long as they have somebody in the house that learns technique, they can do the on-demand with sub-Q. The devil gets in the details when you think about the type of hereditary angioedema they had, because for instance, the sub-Q product is not preferred if somebody had throat involvement before or almost throat closure, and then you want to do an IV. So the IVs, they carry with them, especially if they live in more remote areas, so that they can take them to the ED and do it. The interesting thing is that we face all the time is that these EDs still call us because they don't believe the patient. So despite the fact that we write a letter, tell them what they have and what they need to use, they still think they're confused. They give them EpiPen and steroids, and then the poor patient has to be like calling us and having us talk to the physician to like go over it and tell them to do it as well, which is always an uphill battle. But we try to, as much as possible, whenever we know there are patients in remote areas, to reach out to a couple of their local EDs, especially if in our network makes it easier, and discuss with them, hey, you have this patient with this condition, we can provide education, and also you should have at least like 2 or 3 vials of this medication going. Because the cost is high, sometimes they can't, but it tends to be helpful without, but it definitely can have them on hand to bring with them, yeah.
Thank you.
Dr. Jasudas, are there patients that you consult on in the hospital that you would consider doing IV iron at onset?
So that's a good question, and I think I've gotten into trouble a couple of times for trying to suggest they might need iron in their acute inflamed situation. So when they are actively inflamed, then the general consensus is no. But we have sometimes patients who the acute inflammation is over, they are just waiting to get discharged while other things get settled. And I think there is a role for iron replacement in those patients. They have been occasionally heart failure patients who benefited from IV iron. So I think and again for that patient it was useful to have sent the STFR, the soluble transferrin receptor, showed that there were other lab parameters that indicated iron deficiency. Looking at his peripheral smear was also pretty classical for iron deficiency. So yeah, he was on like 2 liters oxygen, and they could not for almost a week get get him off the oxygen. And after this, he got his iron infusion. In a couple of days, he was ready to go home. Sorry, there's another question there.
Yeah, so it's
the STFR in hemolysis. So I should go back and look at that. I generally don't think about hemolysis elevating your STFR. It can be possible elevated, falsely elevated in your TAL traits, even once you replace them with iron. And if you work in a place with a high population of African Americans, that might be something that you might need to consider because there's a pretty high incidence of alpha TAL traits. It could also be elevated in so that's one condition where we really where we have to look at other numbers as well. So that's one. Otherwise, it is pretty accurate in determining iron deficiency in conditions of inflammation, coexisting iron deficiency, I should say, in conditions of inflammation. I should look into the hemolysis part though. Yeah, that is an interesting point. Do I have any criteria for sending STFRs? No, I think when anyone who has a lower than the accepted threshold of ferritin, I think you have your diagnosis and their STFR doesn't add real value. I think when you have higher than normal ferritins, but less than 500, and everything else seems to be pointing towards an iron deficiency anemia, that is another usual additional test to have.
questions. If you raise your hand, I'm always happy to allow our attendees to talk as well. Go. There's a couple more. Rohit, do you ever do an oral iron challenge with before and after labs to identify poor oral absorption and need for IV iron?
So yes, and I think it's also dependent on which part of the country you practice in. A lot of people have moved away from oral iron challenges. We have found it useful, especially if we have a longer than usual GI referral waiting list. So that is useful. It does tie up a lot of your resources because the patient has to come in fasting. We need to place an IV line. You give them that standard dose of ferrous sulfate and then recheck the labs, I think about an hour later or so. And but it is useful to identify patients that fail that are not going to respond to oral iron. For most patients, though, if we don't have any reason to suspect why they are not, they don't have any GI symptoms and we don't suspect an absorption issue, we give them a trial of oral iron, and if they fail that, then we move to IV iron.
There's another question for Dr. Lopez. How often are C1 inhibitor antibodies used in the diagnosis of acquired C1 inhibitor deficiency? And any idea of the sensitivity specificity of the assay?
So the assay is pretty good in terms, especially of sensitivity. So I'm occasionally complement testing is tricky, like for some of the other types as well, because even transport of the tubes, as I'm sure you're all in the different specialties been running into, sometimes your total complement can be lower just because the tube was standing for a little bit too long. I kind of like go by the history. Usually, if you have really good history for hereditary angioedema or really kind of mediated angioedema, then those labs make you highly suspect of that. You probably will double check at least a second time before committing somebody to a treatment that is also so expensive and has so many considerations and all of that. The autoantibodies. Can you remind me the beginning of the question, Kat? Just because I started.
Yeah. How often are anti-C1 inhibitor antibodies used in the diagnosis of acquired C1 inhibitor deficiency?
So it's placed the whole thing, but it's not like something that as commonly is checked because we go by the other pattern and kind of like the reduction of C1q pointing you in that direction to know that the pathway is used as well. In a perfect world, that would probably help you the most, unless you're running into situations like Dr. Drist's presentation on all the issues the autoantibodies may have, right? But in the setting of somebody that had like a clear clinical reason for it, the rest of the labs can help you do that diagnosis without needing specifically anti-C1 inhibitor antibodies to be proven.
Dr. Failing, there was a question. I was fascinated to hear that migraines and Raynaud's could be associated. Do you have a sense of how often this happens and if it's mechanistic or just coexist?
Great question. Yeah, that is reported as a secondary cause. I can't say a lot of the patients that I see. I mean, a lot of kids have migraine headaches too, so they could just coexist. But didn't really think about that until I was doing my presentation and looking at other secondary causes. So I thought that was interesting as well. But can't say I have a lot of people that have, both. But I think it does have a few where I've had to use calcium channel blockers for that have migraines, and sometimes that's a little more. So high headaches can be a side effect of them, so sometimes that makes a little more a challenge for treatment and trying to find an agent to use. I don't know if Dr. Dries, in your experience, if you had seen any association with this or.
There is one. It makes some sense with the specificity, the blood vessels being sort of more, spastic. One thing that's interesting, and I doubt there's any neurologists in the room, but the newer drugs for migraines, the CGRP drugs, actually can worsen Raynaud's. So just something to think about. There's been some case reports of people who had like scleroderma and then had Raynaud's and ended up with digital necrosis.
Oh, that's interesting.
So yeah, because of the way the CGRP drugs works on the migraines, it like has an effect on me.
Interesting.
And then Dr. Dries, I may have missed it, but is there ever an ANA titer that you would make you concerned for more urgent referral or underlying diagnosis, or does this not have clinical relevance or association?
That's a great question. I would say, so there is more association with higher titer that you could have an autoimmune disease. I've seen plenty of children with 1 to 1280, which is as high as our ANA titer will go, who are completely healthy when I see them. Now, can I say they will always be healthy, never had an autoimmune disease? No. But I don't necessarily follow those kids if they're healthy and I do some lab checks, everything looks okay. I just talk to them about what concerns. I really, when I talk about the INA, it's like the isolated ANA doesn't mean much. Really, it's what else is around it. So if you have a patient who has an ANA and has other symptoms that are concerning, you can, like I said, like you can check off that lupus checklist. Give me a call. I'll get that kid in like ASAP. And I think that's really the key, is the other stuff around the ANA that would make you worried, not the ANA itself. Is that how your same thoughts, Dr. Failing?
Yeah, we have the same thing. I saw someone the other day was 1 to 2,000 healthy. We haven't really been following. It's kind of give guidance on what to look out for and what to come back for and have a low threshold. But it's always tough to think they're really same thing they've been told they have lupus, and so it's a lot of trouble sometimes trying to get them to feel good about it and be reassured. So I think it's difficult too, and they say, well, will it ever happen? I can't say it'll never happen. You'll never develop one. And I think that makes people very anxious and kind of the unknown. But
and if you're ever concerned, I know our program has something called PCTC, gives you direct physician to physician line. I think a lot of hospitals have that. There's anybody you're concerned about, and you have something similar set up, by all means, give them a call, especially, lupus, sometimes the kids smolder and sometimes they go from pretty fine to in renal failure within a couple of weeks. So if there's someone and you've got, checklist, you can check some stuff off, you think really this is lupus, call your rheumatologist and say, hey, I'm worried. And usually, even if we have like a 3-month wait list, we'll get them in.
Okay. Thank you. Other questions? All right. From the hematology perspective, we see ITP fairly often. When would you check ANA in these patients?
Yeah, I mean, like I said, I think that, like I know the little ones, like, you can have like a virus or something that triggers it. I don't know that you have a 3-year-old, I don't think they're going to have lupus, so I don't know that you need to check an ANA in those younger kids. But I do think you've got some weird family history, or especially the teenagers, patients with or demographics that put them at higher risk, Hispanic, African American populations. I think it's reasonable. It doesn't, again, you see the data, it doesn't mean that they'll ever have something like lupus, but I think it's just one more piece just to know, like, how much you kind of have to think about them and watching for other signs.
And Rohith, I just have I guess a personal hematology question, and that is, you had talked about the AAP guidelines coming out for iron deficiency, and we've seen a slew of pediatricians starting to refer patients for ferritins less than 40 or 50 or 60. Do you have a limit of your ferritin that you kind of consider iron replete at this point? And I know this is a loaded question because that changes a little bit with underlying pathophysiology, but wondering if you are seeing the same trends.
So we may be we may be getting more referrals, but we have a pretty high threshold to actually get patients into our practice. We prefer, so if you have iron deficiency without anemia, they don't get referred into our practice. We ask the pediatrician to manage it themselves. I can tell you though that sometimes more than the higher cutoff values, the problem we have is some of our reference ranges have ferritin normal of like 8 to 40, and that is clearly, that I think clearly needs to change. So there have been patients who pediatricians have evaluated the ferritin, found a ferritin of 9. It doesn't show up, it doesn't light up red on their EMR. So they're like, yeah, the ferritin is 9, it's normal. So I think that has been a challenge to convince them that actually you need a higher ferritin, and also to look at the other numbers as well. We do get a lot more questions for iron deficiency without anemia. And again, I have problems treating them with pharmacological therapy. I think there were studies that looked at IV iron therapy for iron deficiency without anemia to see if it resulted in symptom improvement, and the results weren't very striking.
Melissa had just typed in, how can we have a global recognition drive to change the ferritin norms?
That is a
That's a
good
loaded
question.
question.
I think we probably as clinicians need to be able to talk more to our lab folks, our laboratory folks, and tell them. I know in the immune hematology world, we have a lot more interaction with folks that run labs, and there's a lot more back and forth conversations. And I don't think we have it that much in our laboratories as well. But I think starting to educate clinicians in our area, primary pediatricians in our area as well, on normal levels is a good place to start.
Do you have any insight into these AAP guidelines that are coming out? Maybe that'll help.
So I don't know if they're going to comment on iron deficiency without anemia. I do know they're going to comment on especially evaluation of bleeding disorders when you're evaluating for iron deficiency, particularly in girls with heavy menstrual bleeding. And I do know that at least one of the authors, I keep emailing them asking them questions about how we should plan our pathways, and I do know they are going to emphasize on testing at the end of treatment, because I think that is one place where a lot of us fall off on evaluations. Generally, the way we were taught is 3 months, and you treat with therapeutic dose of iron, and you should be good to go. But I think they are going to emphasize on on checking iron profiles and and a CBC at the end of your treatment if it's a straightforward iron deficiency anemia. For patients with inflammation, I think you have to make it up in your practice. One thing I would say is be consistent. If you're treating your patient for a certain duration of time, make sure you check it at the end of it. And as far as evaluating them, one, if they are continuing to have symptoms, it may be worthwhile evaluating more frequently. In a more general practice, and I'm not sure if rheumatologists and immunologists have this question. Obesity is a huge patients with obesity behave like IRIDA, iron refractory iron deficiency anemia, and apparently that's the same in mouse models as well, which I thought was interesting. And people aren't very convinced if it's just the CRP or the inflammation that is what is driving the iron deficiency. And these patients may need to be on longer durations of iron. There is downside to iron therapy as well, which is why I would rather evaluate and see if the patient actually needs it. The GI side effects are one of the common downside that we talk about. But in countries where they try to supplement iron, where they had a very high incidence of iron deficiency anemia, there was actually an increased incidence of malaria in the population that was supplemented. So it does not come with downsides. Same thing for IV iron as well, and especially in patients who have higher ferritins. There's always, once you go past a ferritin of 500, you may be at a risk of iron overload. So so always continuing to monitor them, looking at all the numbers than just one number, I think is helpful in managing patients with iron deficiency anemia.
And then there was another kind of building on that. Are there other lab parameters to follow for patients with iron deficiency state without anemia besides ferritin? I heard about MCH can be used. Not sure if there's evidence to support it.
So some people do use it, but again, not always routinely. Sometimes I think that your transferrin saturation is probably your best companion to ferritin as well. And with treatment, looking at your reticulocyte hemoglobin, I think that's the other indicator to look at. And I think one of the reasons why the AAP guidelines are not out is I think we really can't agree on what seems to be the best. But I think it is important to monitor subsequently.
Thank you. And then there's a question for JP and Kyla. How often do you send thyroid testing for your respective topics? So one of the great mass curators.
I base mine off symptoms. So if they have any symptoms that are concerning to me, I'll get thyroid testing. I will say I send it a lot, but fatigue and obesity is it's never thyroid. Like you think, right, that's going to be thyroid positive, but it's never thyroid. I do think it's one of those things too to be cautious of, not really cautious, but there's a fair amount of people, if you test for thyroid antibodies, that will still be thyroid. And it can take some time to tip over. So it's not an uncommon antibody in the general population. So I usually base it off of symptoms. I will do it every once in a while. I get referrals for urticaria, whether that should go to us or immunology or dermatology is debatable, but there is some association with thyroid antibodies and chronic urticaria. And so it's one of the few cases where I'll test the antibodies and not just the thyroid function.
True, and my answer is similar, and like Kyla said, with the symptoms and all that stuff as well. It's interesting because if you would go by choosing wisely, and the book world, it would tell you, even in patients with chronic spontaneous urticaria, that it's not indicated to send a TSH or anti-TPO antibodies or anti-thyroid antibodies. Then the real world is a little bit different for the reasons we were saying. So even though I try to be as evidence-based as the world approaches, is one of those areas where I more frequently send it than what Choosing Wisely would recommend, mostly if the symptoms are there, as Kyla was saying. And I think especially if you're talking about angioedema, it even becomes more relevant. One thing I prep the patients on that end, even if this ends up being related, because there's a good amount of patients with chronic urticaria angioedema that may have hypothyroidism associated or antithyroid antibodies. If you correct their thyroid disease, actually the hives and the swelling do not necessarily change, so they still need the management they would need regardless. So I warn them it's not a change in management, but it can be a red flag of something else going on as well. So it's part of the couple of labs I send in those situations. Yeah.
I will say that I've had a number of patients that I was like, oh, no way that this is thyroid. And I sent it and they were sky high. So I never know. I can't predict, honestly. So,
I mean, considering the costs you're talking about for some of
yeah.
the tests and some of these medications, I know probably the Choosing Wisely recommendations coming from multiplying this for 380 million people, but especially when you compare with the ANA terrors that Kyla talked about, it's not as likely to induce so much trouble and increasing costs with comparison with other tests that are sent super frequently as well.
It's not thyroid for me, it's celiac. I've gotten into a habit of ordering that in some interesting complaints, and I get a lot of positive results in kids that I maybe wasn't expecting. So I see a lot more weird celiac than I do weird thyroid.
Yeah, I'm with you on that one. I send it a lot. Great. This has been a fascinating discussion. We have about 6 more minutes until the lunch and learn. Does anybody have any last minute questions? I never know how long of a pregnant pause to give you, but it's awkward for me, so I'm gonna cut it off. Thank you all for being here, and thank you so much for your talks. They were really informative, and I really appreciate the time. Melissa, would you like to start lunch and learn early, or would you like to give everybody a 5-minute bathroom break?
I
Or
thought
yes,
we could start at 12:15 actually, to give people a little bit of time to kind of get moving and circulation back going in their legs and all of that kind of stuff. Don't want any DVTs happening while we're having the symposium. Yeah. Go ahead and we're just gonna pause the recording here in the next couple of minutes, and then but please stay on and continue to be with us for our lunch and learn that will start at 12:15.
Thank you all.
Thank you.
We're about ready to 12:15. Perfect. Thanks everybody for joining us for this lunch and learn session. As you know, we are highlighting this dynamic across the ages and the things that we really need to know from the pediatric and adult side, particularly the adolescent and young adult population. And so we're really grateful to Drs. Frey and Unguru for joining us today. I will just do a quick introduction here. Dr. Frey recently completed his fellowship, congratulations, and currently is a pediatric allergist, immunologist, and clinical assistant professor at the University of Michigan. During his medical school training, he completed his master's degree in bioethics and medical humanities, and his primary interests are in food allergy and bioethics. And my good friend, Dr. Unguru, we were pediatric residents together. He is a pediatric hematologist oncologist with joint faculty appointments at the Herman and Walter Samuelson Children's Hospital at Sinai and the Johns Hopkins Berman Institute of Bioethics, where he was a postdoctoral Greenwall Fellow in Bioethics and Public Policy. He's an associate professor in the School of Medicine at Johns Hopkins, and his scholarship has focused on the role of children and providers in facilitating shared decision-making, end-of-life decision-making, allocation of scarce life-saving medications, and ethics education. Dr. Ungaru has served as an ethics consultant to national organizations, as well as certainly local and regional ones, and has been chair of the Children's Oncology Group Bioethics Steering Committee. So welcome to both of you today, and I will be pleased to hear what you have to say.
Great. Yeah, thank you guys so much for having us. Again, we'll be talking about the emerging autonomy in the adolescent and young adult populations. And, today we're, like Dr. Rose was saying, we're going to be focusing on the AYA population. We're focusing on that liminal space between the young children who have kind of a limited understanding, limited input in their care, and the fully realized adult who, is making independent medical decisions. And to that, we're going to, I'll first review some traditional understanding of autonomy and medical decision-making for minors. Then I'm going to talk about the concept of emerging autonomy, which is newer in the field, and how it relates to the adolescent and young adult population. And then Dr. Ungaru is going to take over and talk about some real life cases that he's come across with his time in the with the consult team at his institution. So let's talk about autonomy and medical decision making for minors. So starting, with the very fundamentals, what is autonomy? And that is the belief that a person should be able to exercise self-determination that is free from both controlling interference by others and from limitations that prevent meaningful choice. And there's two conditions that are essential for autonomy. The first is liberty, which is independence from controlling influences, and the other is agency, which is the capacity for intentional action. And these two conditions are interesting to think about because in reality, it's very difficult to truly meet both of them. So first is liberty, which again, independence from controlling influences. It's really kind of hard to achieve. You may have competing interests from your family, from society, limitations set out by your financial background, your immigration status, etc., right? The other is agency, which is essentially having capacity. This is how autonomy can be limited in the cases of diminished capacity, including suicidal ideation, psychosis, unconsciousness, etc. That's kind of the basis for how we can do that. Traditionally, by definition, minors lack autonomy. And the reasoning behind that is this second condition of agency, right? Minors do not really have agency, again, traditionally speaking, and so they can't really have autonomy. And since minors lack autonomy, medical decision-making for children relies on surrogate decision-making. Let's say someone else is making the decisions for you. And discussions around ethical dilemmas in children typically focus on beneficence and non-maleficence as opposed to autonomy, which is often the case in adults. So again, when we talk about ethical dilemmas in adults, when we're doing ethics consults in adults, autonomy is almost always brought up as one of the principles that we're weighing in our dilemma. Much less common in children, again, in the traditional sense, because we usually don't think of autonomy in this age group. What are the exceptions to that? So as a profession and as a society, we've agreed there are certain situations where a minor is able to make their own medical decisions and provide their own consent. You might have heard this termed colloquially as the areas of sex, drugs, and rock and roll. Specifically that's sexual health, drug use, mental health, etc., right? And generally, the law matches what our professional societies and guidelines have set out. And so if you follow what the AMA, the AAP, the ACP have determined as situations for medical decision-making for minors, you're typically following the law. Of course, though, that does differ from place to place with things like the lower age limit, the specific services, such as mental health counseling versus mental health pharmacology, things like that. But again, that's generally how we view places where adolescents have autonomy. In the cases that aren't the above, really the default is given to the parents or the guardians, and they're really given a great deal of latitude when it comes to medical decisions for the child. And this has really been enshrined all the way back in the Supreme Court back in the 40s. when informed consent and things like that were just becoming kind of national interest. And so we really have a long precedent that parents or guardians have pretty broad latitude when it comes to making decisions for their children. That being said, we know there are limitations to the powers of the guardian, and providers can intervene when they're concerned about their best interest of the child. And this is considered valid under a certain legal doctrine. It's called parens patriae, or parent of the nation. And this involves a lot of different things, but really what it comes down to is that the state has an obligation to care for those that cannot care for themselves, which includes minor children. And so, you know, the provider is acting by proxy in this case. You know, they raise their concerns to the state, and then the state makes a determination, right? But really what this all comes down to is that when we think about medical decision-making for minors, it's about the best interest for the child. And typically the parent or guardian decides what is the best interest of their child, and they're the default. However, sometimes, you know, we intervene as the provider, or sometimes it's the minor themselves that gets to choose what is in their best interest. But, you know, as you can imagine, it kind of makes it hard sometimes to determine who's in charge in a situation, who has the ability to determine the best interest, to provide the consent, to provide the medical decision making for that young adult or adolescent. Okay, and so that brings us to emerging autonomy, and we're going to shift gears a little bit, and this is going to add kind of another wrinkle to that previous discussion. So in the traditional view, in the eyes of the law, the patient goes from no decision-making capacity, beyond the exceptions we talked about, to full decision-making capacity on their 18th birthday. And as you can imagine, there are many pitfalls to this approach. Again, this is a very sudden change. The day before your 18th birthday, your parent or guardian has to sign a consent for you to get something as simple as a vaccine, right? The day later on your 18th birthday, you can consent to organ transplantation, elective surgery, pretty much anything, right? And it makes me think of this movie 13 Going on 30, which I'm sure some of you guys have seen, but essentially what happens is the main character, she goes to sleep one day as a 13-year-old and wakes up as a 30-year-old, right? And with all the responsibilities and things that come along with that. And sometimes when we think of the law, that's really what happens to these patients is this sudden transition, right? And so what are some of the issues that come along with this abrupt change? So first, as we've all heard multiple times, especially the pediatricians, we know that adolescent brains are not fully developed, and some research indicates that full maturation can extend into the 30s, right? So we know that our brain is developing even after this point where we're considered an adult. We know that adolescents and young adults have evolving personal values and priorities, right? Beyond the medical realm, this is just a major developmental milestone in general, right? And these patients may be confronted with new social roles, changing circumstances such as leaving home, starting or finishing college. They're entering the job market. For some, there's marriage. For some, there's parenthood. And then there's a bunch of different unanticipated events, one of which will be health issues, right? And they're navigating all this for the first time as an adult or a young adult or an emerging adult, right? If they're not quite 18 yet. Another kind of practical consideration is that many adolescents and young adults remain dependent on their parents' insurance since passing of the Affordable Care Act, which did expand access. And to remind everyone, it can keep you on your parents' insurance till 26. But it really puts them in a unique position where they may be dependent on their parents for financial security. And the parent, while not able to access medical records per se, can access explanation of benefit summaries for their children and anyone on their policies, right? And so the line gets a little blurred when it comes to what information they have access to, even in fully fledged adults, because of this wrinkle of insurance and the payer and all that. And on the other hand, we need to acknowledge that the strict 18-year-old cutoff also does a disservice to those minors who have tremendous insight into their own medical conditions and health, especially in the chronic illness population. And I'm sure all of us have examples of patients who are 15, 16, 17, who could likely function independently as medical decision makers if needed. And really the only reason they don't at this point is because of their chronologic age. To continue on that, so The cognitive and emotional regulation skills required to make decisions obviously evolve during adolescence. We do know, and research does show, that youth as young as 14 can really understand quote unquote adult medical information and come to reasoned decisions resembling those of young adults and older adults, right? And so when they present medical information in these kind of fictionalized studies, again, kids as young as 14 come to the same conclusions that a quote unquote reasonable adult would come to. That being said, though, we also know from research that teenagers are less likely than adults to engage their rational decision-making abilities in emotionally fraught situations with psychosocial implications, such as important or stressful medical decisions. So even though in a controlled environment, we know that they can come to these same conclusions generally, they're more susceptible to the stressors that anyone is susceptible to, but they're particularly susceptible in this age group. And so, as opposed to kind of the abrupt transition that we kind of deal with on a day-to-day basis, I like to kind of conceptualize emerging autonomy using this kind of metaphor of the caterpillar and butterfly, right? The caterpillar is the young child all the way on the left who's totally dependent on their guardian for decision-making, right? The pupa is the adolescent, the young adult who's developing their autonomy, and it's through various stages through time. It doesn't look the same at any given moment, but eventually they become the butterfly who's fully realized individual, able to express their autonomy fully. And again, from a legal perspective, that's an 18-year-old. But from a developmental perspective, that age is not defined, right? And someone that could be a 16-year-old, right, who is fully developed, fully autonomous from a developmental standpoint. But it's someone else that might not be till they're 21, for example. They really don't have the capacity to make these decisions, maybe to what we would like, and not able to really be autonomous. Again, this is not about their chronologic age. This is more about their development and about their autonomy and how they express it. And the truth is here, there's really no clear precedent about when an adolescent minor's decisions can become prevailing beyond those couple situations we already talked about. And this is true both in the law and by professional standards. I wish there was some like hard and fast rules that we could really kind of give, but there really aren't. And again, this is still kind of like a newer concept in the field of bioethics in general. But I do want to highlight some defining paradigm cases in the last 20 or so years that were pretty big in the traditional kind of news media. You might have heard about some of these cases, and you'll see just that they all have various outcomes, which demonstrates just how we haven't really reached consensus on this. So the first is Cassandra C. She was a 17-year-old girl in Connecticut with Hodgkin's lymphoma. She refused medical treatment along with her mother, who agreed with her. The court ruled, though, that even though she was less than a year from her 18th birthday, she was about like 8 months short, she had to undergo the treatment for the Hodgkin's lymphoma based on the fact that she was under 18. E.G., the next case is E.G. She was a 17-year-old in the state of Illinois with leukemia. She was also Jehovah's Witness. She had about a 20% survival prognosis. She refused blood transfusions due to her religious beliefs, and her parents agreed with her. She was found to be a mature minor and allowed to refuse the treatments and died. That being said, the court explicitly said that if the mom, in this case, had disagreed and had wanted her to be treated, they probably would have ruled differently. But because the mother also agreed, they said that E.G. was allowed to refuse. The next case is Dennis Lindbergh. He's a 14-year-old boy in Washington State. He had leukemia. He's also Jehovah's Witness. You'll notice kind of a theme here. He also refused blood transfusions at the age of 14, and his guardian, who was his biologic aunt, who raised him from birth, also Jehovah's Witness, agreed with him, supported the decision. His biologic parents, who were not in the faith, tried to get a court order for transfusions, but ultimately the court ruled that he was able to refuse the transfusions, and he passed away. Then the last case I wanted to highlight is of star child Abraham Cherix. He was a 16-year-old boy in Virginia, also with Hodgkin's. he and his parents wanted him to be treated by the Hoxsey method in Tijuana. You might have heard of this. It's like a plant-based therapy run by someone out there. And this case kind of had a mixed outcome. So the court ruled that he had to pursue traditional medicine within the state of Virginia, but the parents were allowed to keep custody of him and were free to pick the doctor. So they could try to pick a doctor who also welcomed some alternative methods. That being said, though, the aftermath of all this was that the state ended up passing a law that gave adolescents who were 14 to 17 better standing to refuse medical treatments. So they basically said the law as it was in Star Child's time, he had to get treatment, but they didn't actually like that. And so they changed the state law after the fact. And so now if a similar case were to come up in the state of Virginia, there's a good chance they would actually allow the family to pursue this alternative therapy. So you can see from these examples, there's really no clear indication state to state what an adolescent's authority actually is. Interestingly, these states have generally similar laws when it comes to things like minors getting abortion and things like sexual health. You know, Illinois, Connecticut, Washington State, they all kind of follow each other with those things, but how they differ in these cases of life-saving therapy, which is pretty interesting. And the other thing to point out here is that all of these paradigm cases had the minor and guardians agreeing on the treatment course. We really don't have a lot of examples of when the adolescent and parents disagree on the medical decision making. Like, let's say the adolescent refused what the parents wanted and vice versa. And so that means we have little guidance really when it comes to that in clinic. So I just wanted to stop there to see if there were any questions on kind of the bioethical theory about the law, anything like that anyone had before we got to the cases. See, I'll check the chat maybe. Okay, so okay, so now I'm going to hand it over to Dr. Ungaru. He's going to walk us through some real life cases he's encountered. And as we discuss them, try to think about the issue of emerging autonomy. Beyond the ethical considerations, which are obviously important, think about the practical considerations, right? Like, how would you force, quote unquote, a treatment on an adolescent who's refusing it? And as we go through the cases, again, I would just want to emphasize this is a relatively hot topic. We really don't have a lot of consensus on how we treat the emerging adults. There's no right or wrong answers as we go through the case, right? Just try to think about what you would do, your own biases, your own kind of instincts and things like that.
Thank you, George. That was an excellent presentation and overview. And I'd like to thank Melissa and the conference organizers for asking me to speak. I am hopeful that your postprandial state hasn't entirely developed and all of the blood is not in your intestinal tract and some is still left upstairs in the penthouse, because the hope that George and I have is that we will actually be able to hear from you and discuss and engage with you about the two cases that we're going to share. Otherwise, you're going to be stuck listening to George and I wax poetic, and nobody wants that. But I do want to share with you a couple of cases that I have been involved in, which really exemplify many of the attributes and considerations that George so nicely presented. So hopefully I can advance. Let's see. Yeah, okay. The first patient, we'll call him SA, and he was a 19-year-old with hemoglobin SS sickle cell anemia that had not a atypical course over the span of his life. He had a splenectomy due to episodes of splenic sequestration earlier in life. He had had at least one, if not more, prior episodes of acute chest syndrome, but really since adolescence, he had been dealing with chronic pain. Consistent with what we heard from George in some of the cases, SA was a Jehovah's Witness. I have to say that he was always a very thoughtful, deliberate, and mature kid, and that certainly continued as he developed into a teenager and then young adult. The present case, as it were, involved SA coming to the hospital in an acute pain crisis in the setting of an aplastic crisis. And you can appreciate he was quite anemic, and he really didn't have any reticulocyte count to allow him to produce more red blood cells. Not surprisingly, based on his long-standing expressed preferences, SA refused blood transfusion. And so, consistent with the kind of standard in these situations, we started erythropoietin, folic acid, B12 vitamins, but we really did not get much of a bang for our buck, and he didn't get much of an improvement. Clinically, SA wasn't that alert or arousable. He was pretty drowsy, and he was in and out, if you will, in terms of his ability to engage with us. Not that surprisingly, also, his clinical status worsened. He had a greater degree of hypoxia. He developed much more intense chest pain, and unfortunately, he developed another episode of acute chest syndrome. At that point, SA was transferred to the PICU, who he had alerted in advance that this was likely going to happen, and there was a concern for high output cardiac failure. We spoke with our transfusion medicine and bloodless colleagues, and the decision was made to initiate both the erythropoietin and darbepoetin, because as you can see, the already low hemoglobin became pretty abysmal, under 2 grams per deciliter. SA was consistent. In fact, I would say he was resolute. He was not interested in a transfusion of red blood cells. And he maturely decided that he wanted to have his code status changed to DNR and DNI. And it didn't take long before he developed an arrhythmia, and unfortunately, he died with his grandmother at bedside. And I realize there's a typo there. It should say SA, not AS. So I wonder if any of you guys out in Zoom land have any questions, anything about this case that you would like to know, or any comments, because George and I have some questions that we would like to pose to the group, but a good ethics consultant typically only presents more questions. Sometimes we actually may have an answer, but please feel free to unmute yourself and fire away.
I think potentially because of the webinar format, we might not be able to unmute necessarily, but you can raise your hand and I think we can individually call on you that way. Or you can put stuff into the chat or the Q&A box for that bit of interaction. Apologize for that.
Thank you, Melissa. And I can't see the chat, so if you're able to, and if you wouldn't mind moderating, that would be great.
Yeah, sure. My question, I actually was, as you were going through this, just very quickly, did he ask for the DNR, DNI, or was he being asked repeatedly by all of the caregivers who were participating in his care?
Not your first rodeo. Some of our PICU colleagues at my hospital oftentimes are pushing for this. It was pretty clear to us from the outset, because we knew him well. We'd been caring for him since he was an infant, and given his clinical presentation, that this was a likelihood. And so this was broached by his primary hematologist very early on, that this was something that SA was going to need to consider and give us some insight. And so that actually was from the outset. And I would say that this was, with the exception of that introduction for the importance of considering his goals of care, this came expressly from him.
One question I had is, it sounds like he was not terribly with it towards the end here. Is when was he able to make those decisions for himself at that point, or would he have had someone making them for them, or did he have some established, plan in place?
Wonderful question. Thank you. This was one of our questions as well, is even though SA was always, as I mentioned, thoughtful and mature in his decision making, even before he was legally able to do so. We wondered whether he had the ability to make that decision. I mean, if your hemoglobin is 3, let alone 1.7, you're probably not perfusing your brain that well. And we struggled with this. We ended up really relying on the long-standing relationship, which is very important, not only clinically, but certainly ethically. We had the benefit of knowing SA. We also had the benefit of a prior hospitalization when he developed a fairly significant degree of anemia, not as profound as this, where he also expressed those opinions in that manner. But I think your question is an excellent one, and we felt reasonably confident that this was a preferred expression of his views, and that the fact that he, even though he may not have been as able to make that decision, it was one that he would make were he able to. I don't know if that answers your question adequately, but that's the approach we took. Other questions, clarifications, comments?
One
Is
more
anybody? Oh, sorry. Go ahead.
So here he's 19, he's an adult, right? But let's say he was 17 and you had the same patient. Would you have felt that he needed to receive the life-saving blood transfusion? And would you have overrode his concerns at that point?
So I promise that is, and I don't want to mispronounce, am I pronouncing your first name? Is it Kyla?
Yeah.
I promise that Kyla is not a plant, but if I show you my next slide, you're going to see that 2 of these 3 questions are Kyla's questions. So kudos, Kyla. Well, so a good ethicist always pushes things back. What do you think? What would you do if he was 17 and not 19?
I personally would really have a hard time not giving him the blood, but that would be me. But I think I would definitely have an ethics consult in that situation.
So that's always good, right? We always call our friends. I mean, I call Melissa when I have a kid with a challenging hematologic disorder that's beyond my abilities all the time. And we certainly should do that in these situations as well. If I may, Kyla, so is your push to give the transfusion merely because he's not legally an adult, or is it for another reason? George shared some data about a study that was conducted by Wythorn and colleagues back in the 80s and then repeated in the 90s that showed that adolescents age 14 and older are as able as adults when it comes to making decision making. He also was savvy enough to qualify that study, showing based on neuropsychological and functional MRI data that kids' frontal lobe is not all there, and so in ideal situations they're able to, but not in kind of hot situations. And so, are you able to share what exactly it is that gives you that internal ick that you're not, that you would push the transfusion if he was 17?
I mean, he's legally not an adult, and I would consult ethics because this is just a quagmire, right? I just, if it was something like, I have an easier time if it's something where you have a 20% survival rate, right? Like the Hodgkin's lymphoma, who has a high likelihood that they're going to die anyways. But somebody, if we felt like if we could give him blood and save his life, it's a really hard thing for me to turn away from. But yeah, there's definitely a lot of considerations there. Granted, I'm not thinking the top, I'm not going to one that's going to have to make the call.
No, but your point is an apt one. This is an irreversible decision. There's no takebacks. You know, this is by not transfusing him, we're pretty certain of the outcome. In fact, we saw the outcome. He died. And we had the luxury, if you will, the fact that he was an adult. But by transfusing, you're probably going to be able to save his life relatively easily. And so this is something that we're going to come back to towards the end of the second case. So keep this notion in mind, this idea of irreversibility and the severity, if you will, of a given decision. I wonder if anybody has any thoughts about the first bullet I have up here, the notion of how influential are other people in a particular person's decision. And this is something that is especially apt in cases that involve patients who are Jehovah's Witnesses. Does anybody have any concerns? A good historian will include information that hopefully is relevant and not everything. And I mentioned there that his grandmother was at the bedside and she had always been involved in his care, and she was also a Jehovah's Witness. And so there's this consideration, I think, as well. Is anybody have any thoughts about that? I mean, we're all influenced by other people. There's not before some of you may have logged on, you may have heard George and Melissa and I was talking about my wife Gila, and she influences me understandably every day. And decisions that I think I'm going to make, I oftentimes will reconsider after hearing from her. Should we be surprised that other people in a patient's sphere of influence will alter their decision making? Should we accept that? Are there certain limitations?
Or
Personally,
to
nobody
ahead.
lives in a vacuum, right? Like, I think we're all made up of all of the different things that we've encountered along the way and have influence, even if we don't always recognize that influence. Certainly in this case, with an upbringing of and being raised in a Jehovah's Witness family and environment, that would certainly have a big effect on the decision making. But acutely, I feel like sometimes, the adolescence is a time of growth and trying out new things. And, if the grandmother who's been your guide throughout all of this is sitting right there, sort of like hovering over you and really directly influencing that decision, that might be very different than, if you've already kind of gone through the process of accepting Jehovah's Witness as something that you inherently also have as a faith. So those things are also different.
Absolutely. Thank you, Melissa. George, I think you were gonna.
Yeah, I was just gonna say, in this case, it's very clear that SA is very mature, right, and has always been mature and has good insight. But there's obviously also a lot of patients who are the flip to that, where they're 19, but really are pretty immature. You ask them things and they're like, well, whatever my mom says or whatever my dad says, whatever my parents want to do, I'll do. So then it's like, how do you feel in those cases? How do you guys kind of approach those cases, right? Or at that point, if you're like, well, I know this person's actually very immature, I don't actually trust them to make this decision, but they're refusing life-saving therapies. Like, how do we address that?
And I think this speaks to the importance of knowing your audience. For our colleagues who are emergency physicians, I always cringe at the challenges that they're faced in some situations where they have no basis to know the veracity of the individual's preferences and values and wishes and how those influence a particular decision. But for many of us, at least on the HEMONC side, we have the luxury of knowing that. I would be remiss, however, if I didn't mention the importance of not just the family members, and this is absolutely not unique to Jehovah's Witnesses, although I think it's something that we encounter more frequently, is the influence of the larger Jehovah's Witness community. And that's for not bad only, but good as well. I've encountered over the years very thoughtful members of the extended Jehovah's Witness faith community who have provided important insight that has helped us navigate some of these challenging clinical and moral decisions. But at the same time, I have also encountered members of the extended community who are driving an individual patient or that patient's family's decision. And so just like a good adolescent medicine pediatrician will kick the parents out to get an accurate history, a good ethics consultant will kick out the members of the larger community to find out is there undue influence or pressure on the individual patient or family to make a decision that they're not entirely consistent with their beliefs or values? And that is one element of voluntary decision making. If I'm standing over George and I'm in the room next to him and I say, George, go get me a cup of coffee now, and I'm saying that in a threatening manner with my arms crossed, George may not feel free to reject me, even though that's what he wants to do. And so that's an important consideration as well. All right, we're going to move on to the next case. And this next case really was a challenging one for my colleagues and me in particular, since I was the primary doc. So the next patient, we're going to call him JD. And at the time that I met him, he was 16, and he had at least stage 2A Hodgkin lymphoma. And that will become clear why it wasn't clear shortly. And that's associated, for those non-oncology folks among you, with about a 90% plus cure rate. He first noticed some swelling of his neck in October, and by the time he came to see me was several weeks later. And like good oncologists, we scan things, and so we indeed got a CAT scan, and it showed, not surprisingly, fairly significant lymphadenopathy involving the neck, the mediastinum, and beyond. And the mass was sitting up against the trachea, and JD's and his parents agreed to a surgical biopsy. And when his parents learned about the diagnosis of Hodgkin, they were pretty matter of fact. I mean, I've got enough gray hair. Maybe you can see that not my first rodeo. And I tend to have seen, dozens and dozens and dozens and hundreds probably of parents when they learn about their child's cancer diagnosis. And this was very odd. And although his mother agreed to the biopsy, she was against anything, as she said, invasive. And so she refused the rest of the workup. She also refused placing a portacath so that we could safely give treatment. And when I asked her what the basis for her refusal was, she said it was a religious refusal. And I asked what religion, and she said Christian and no particular sect. And she went on to share with me that she felt that the body is God's temple and it shouldn't be poisoned. And those were her words. Mom was concerned that chemo and if radiation therapy was necessary, that would weaken JD, and she preferred to pursue naturopathic remedies. And I asked JD how he felt about this, and he said, well, after I told him about the diagnosis, he prayed, and within 2 hours, he said God answered his prayers and had specifically instructed him not to accept chemo or radiation therapy to treat the cancer. And when I asked JD's father how he felt about it, he said that neither he nor his wife would want to hinder JD's faith or his morale, and they believed that the cancer presented a test to JD's faith. I asked JD and I asked his parents, I said, do you want to die? I mean, if you don't treat this, that's what's going to happen. There's few things that are guaranteed in life, but this is one of them. And JD and his parents said, no, of course I don't want to die. JD then offered the following direct quote, whether I live or die is in God's hands, and should I die, so be it, as it's God's will. I offered a second opinion. I mean, we actually had a very cordial relationship, educated family. Dad was an aeronautical engineer. Mom was a stay-at-home mom. Nothing about the relationship was adversarial, and that made it feel even a little more challenging. But they didn't want a second opinion. They said, we like you. And so when I asked JD, I said, okay, you don't want to die. So how are we going to treat your cancer? And he said, well, I want to do some dietary changes and some immune therapy. And I said, well, where'd you come up with this? And he said, oh, internet searches and watching online videos. The family wanted to do naturopathic medicine, but they reached out to various naturopathic folks in our state of Maryland, and nobody would accept JD as their patient. And ultimately, they found something called the Budwig Center in Spain, and Costa del Sol, which is a beach resort in Spain. And when you look at their website, there's no mention of any pediatric-oriented staff. And these were the treatments that were provided and offered for things like cancer, hyperthermia, sunbathing, oils, massages, trampoline therapy, etc. And here are some quotes actually from Dr. Budwig. And I have a couple slides here. It's important, I think, for folks to hear these so that you can gain a perspective for what our patients are hearing. So Dr. Budwig herself talked about noticing that patients with cancer had this strange green-yellow substance in their blood, and she wanted to develop a healing program. So she went for, as she called, human trials, which I assume mean trials, and that she enrolled 600 patients from 4 big hospitals in Germany, and she started to treat them with flax oil and cottage cheese. And she goes on to say that she had a very good response, as you can see, that she treated over 2,500 or approximately 2,500 patients with a success rate of 90%. She goes on to say some things that also from the website that the basis for this treatment is this organic cold pressed flaxseed oil plus cottage cheese, which is called quark, and that mixing these together, it provides what is called the spark plugs for cells to breathe. Here's another quotation that is essentially equating cancer to a virus. And the cancer is caused not only by microbes, but by nutritional deficiencies and hormonal imbalances and negative emotional trauma, etc. And again, speaking about the benefits of this quark. This is right here, Costa del Sol. I absolutely want to go there. And I think anybody would feel better just by being there because of the serene views and what seems to be like the nice area, although I'm not sure that it's what I would choose for treating cancer. At the time that JD's parents were looking to go to the Budwig Center, the price for the 2-week gold program, which included the hyperthermia and the trampoline and this and that, was over 10,000 euro, and the 1-week silver program had increased to 7,000 euro. And a recent check of the website showed that it closed in March of this year due to circumstances. That's all it says. It doesn't say what those circumstances are. But the online store, for those of you who are interested, is still up and running. And for $2,800, you can buy a 4-in-1 mattress that incorporates hyperthermia, and needleless acupuncture, and other things. And for $2,000, you can get a hydrogen generator, or for $2,000, you can get a spinal healing wand. And several of the devices include references to NASA research that supporting their efficacy. So, following failed attempts to negotiate with JD and his family and an ethics consult, we still hadn't made any inroads. And so we activated CPS, and we didn't want to, but we had no choice, we felt. And when my social worker colleague contacted CPS, she was told by the CPS worker, well, JD is 16 and he has a religious based refusal, so there's nothing for us to do and we're not going to take the case. And I get dressed up for Halloween every year at the hospital. And when my social work and clinic colleagues saw me hear this, they said that I became the hope. And it really was a testament, I think, to the importance of knowing who to call. I ended up having to call the CPS supervisor. I ended up actually going as far as the state assistant attorney general before CPS agreed to take the case. And so they did. And so we went to court, and I testified both as a pediatric oncologist and as a pediatric bioethicist with expertise in adolescent brain development, if you will, in terms of decision making. And the circuit court judge was a very thoughtful man, and he really focused the attention to the limits of parental decision making. In my state of Maryland, there is no mature minor doctrine, so that made it easy, meaning JD was deemed a minor. And so, as we heard from George, he lacked decision-making capacity. But what the judge did was he recognized the family's freedom to religious beliefs, but he said there's this thing of separation of church and state, and we're not even going to talk about that. And the judge decision was focused on the facts of the case and the imminence of the underlying diagnosis. The notion that without treatment, this was uniformly fatal, and that with standard treatments, there was an approximately 90% survival rate and cure rate, That's why the judge decided that he's going to override the parents' decision and they have to abide by the medical team's recommendation. And he left the family with this quotation from scripture: render unto Caesar the things which are Caesar's, and unto God the things that are God. And I'm not a religious scholar, but I looked this up, and it seems that of the various interpretations, it's meant to reflect that the authorities are here by virtue of God, and therefore religious people should recognize the authorities' decisions, because otherwise you're essentially dissing God. So a month later, JD comes back to the hospital, and disease has progressed. Not surprising. He has bulky disease. He has B symptoms. He's coughing. He's lost weight. You can see that the mass is progressed. We had to start steroids emergently. We were not able to complete the staging workup, including a bone marrow procedure. And his parents actually had to agree to chemotherapy. And so when they signed the parental permission or consent form, they signed under court order. But they refused to allow us to give him medicine for nausea. And our chemotherapy is gross. It causes you to be nauseous. And this was allowed by the court, but I really think this subjected JD to a degree of suffering that was really unnecessary. And because we weren't able to do the bone marrow procedure, that precluded him from being eligible for a clinical trial that at the time was investigating a new targeted immunotherapy drug called brentuximab vedotin that has subsequently been shown to be superior and is now the standard of care. So had all of this not happened and his parents been willing, he could have potentially gotten a much better therapy, but he did not get that. We actually ended up going back to court, at least another, if not a third time. The parents appealed. And I've given you some quotations here from what the mother stated in her affidavit. And I'm not going to read them for you. You can see them for yourself and read them for yourself, but I draw your attention to the last one. The mother said that my son has made the decision to trust the same God I have taught him to love and follow all of his life. And this brings back this notion that we spoke about, George talked about earlier, and I mentioned earlier, about the influence of others, and was JD's decision truly voluntary? So that's the case. He completed therapy. He ended up needing radiation therapy because of the delay and his disease progressed. He would not have needed radiation therapy had we been able to start from the get-go when he presented. Because of his shenanigans and the concern that the family wouldn't come, he remained inpatient 5 days a week for outpatient radiation over the span of the 3 or 4 weeks that required. So lots of resources. Security had to come and take him to the radiation oncologist. He actually ended up having to get sedated for each radiation session. That we normally would not do for an adolescent. There's risks associated with that, obviously. There's resource allocation issues. So a lot of issues. And as you probably can tell, it certainly scarred me to a degree. So happy to open this up. I think we've got about 10 minutes for questions, comments. I've got some thoughts as well to share. Please feel free to raise your hand. And as Melissa noted, we can unmute or go from there.
I think this case is very interesting, and I'm glad you presented both of these because you have the long-term relationship with a family and patient versus this sort of out of the blue thing. And I feel like we're faced with these, maybe not quite these cases on a regular basis. And I think it's much more difficult, even if you do develop a good relationship with them in a short period of time, to be able to have a good understanding of what an adolescent or young adult is actually thinking in the course of things.
Yeah, couldn't have said more better. Thank you, Melissa. I mean, it really, and I do think the fact that they were Dad was very polite. Mom, not so much, but still respectful. it actually made it harder. You wanted to like them, but George shared the seminal Prince versus state of Massachusetts case, and it was, I think, Supreme Court Justice Brandeis maybe, who, if I recall correctly, said that parents are free to treat their own anemia with rubbing oil, but not that of their children. Our job as pediatricians is to protect kids from the consequences of others' decisions, including decisions made by loving parents. Just because you're a loving parent doesn't mean that you always do the right thing. And as far as I'm concerned, there's really two main ethical questions that this case and similar ones like it force us to ask ourselves. One is an adolescent truly mature enough to make medical and religious decisions on his or her own? And the second is, does our obligation to respect a child's emerging or developing autonomy, like George spoke about, or that of his guardians, does that take precedence over our obligation to provide for that kid's basic needs? And I think when we're considering this, we should consider two situations. The first is, if you have a treatment that's relatively safe and very effective versus a treatment that has less likelihood of success or a very advanced disease state. I think many of us would probably say that in that first situation where you've got an effective and safe treatment, the court should compel treatment. But in the second, not so much. So, in my oncology world, think about a kid with metastatic Ewing sarcoma with a very poor prognosis. If the family didn't want to treat, I think we'd be much more inclined to respect that. The problem is, as George shared, we don't have data. I think most of us would say, if you've got a 20% chance of cure, we're going to recognize and respect the family's wishes. If you've got an 80% chance of cure, we're probably not if they want to refuse. But where do we draw that line? And if we were to poll the group here, some of us may say 50% is where you draw that line. Some would say 60, some would say 40. We really need data. And the AAP, though, does actually have some guidance here, the American Academy of Pediatrics. Specifically, there's this notion of what we call a threshold level of capacity, meaning where you have a high risk situation, you need a higher threshold. Where you have a low risk situation, you have a lower threshold. And of course, there's a lot of wiggle room in the middle. George, did you want to jump in there? I saw you unmute yourself. I wasn't sure.
Oh no, I was just going to add too that there's obviously the prognosis question, but then to complicate things, you have side effect questions. You might have a good prognosis, but come with horrible suffering, or how do you weigh that, and things like that. And when it's even more complicated for us who do immunology because, for example, I think that the best allegory for us would be stem cell transplant in certain immunodeficiencies, right? Where you do have it's the quote unquote standard of care. You do have good prognosis, but you can also have very, very bad side effects, very bad outcomes too. So even I feel like I'm not a hematologist, but I feel like there's even more kind of you can have some more drastic outcomes with stem cell transplants than you do with some of these like very standardized chemo treatments.
Absolutely, and in fact, if you look at the requirements and if you look at the responsibilities and rights of surrogate decision makers, parents are legally allowed to refuse life-saving treatments if, on balance, the side effects are significant enough. And so you could have a fairly good prognosis disease, but the courts oftentimes will side, George shared some of those cases, with families when the side effects are significant enough. But again, where does one draw that line is a bit of a moving target. I will say that when you look at the court decisions nationally for these high profile cases, the ones that George shared and many others, there does seem to be a trend among the courts where they respect the refusals of older children, 14 and up. It's quite rare where the courts will side with parents who are refusing a recommended treatment for a young child, someone who's not an adolescent. And there's lots of reasons for that. I was very pleased that the judge in the case of JD really reaffirmed my belief in the judicial system. Talk about a thoughtful man. And we could have fallen on a judge who wasn't as thoughtful, but he really was good in that way. And the fact that he made a decision that I actually wanted, of course, didn't hurt, but independent of that, truly his approach was a very good one, I think. Other questions or comments, or would anybody have done something differently?
As one question. Oh, go ahead.
Can I pose another scenario?
Yeah,
So
please.
if JP had wanted therapy, but his parents were refusing, how would that approach have been different?
George, do you want to take that, or should I?
Yeah, I think in that case, you would. I mean, again, he couldn't legally provide the consent, right? But I think your case to CPS would be a lot simpler, and you'd be a lot quicker. You know, the movement would have been a lot quicker, I think, because there's kind of very little in that case besides a signed document, which is keeping him from his treatment because he wants it and provider wants it. So, you know.
I agree. And Lainey Friedman Ross, who's a pediatrician and philosopher who's now in upstate New York, has written about this extensively. And she has a nice little 4-box, if I recall, kind of approach to these. And when it's hard pressed, not only for us clinical types, but for the legal system to ignore a child who wants to be treated. Of course, accounting for all the important extenuating circumstances. Other questions or comments? Well, I think we're right at time. Yeah, Melissa?
Yeah, I think so. I mean, I think I wanted to end a little bit and just say that, you know, while these were hematology cases, as George alluded to, they're not, you know, just hem-onc cases, right? There's the acute sepsis in a patient. There's, you know, from the infectious disease perspective, you know, your chronic CGD patients and those sorts of things, and what sort of therapy they want to use and not use. So I think there's a lot of different things that we can all relate to within our disease specialties. And I really want to thank both of you for bringing all of this to our attention and generating a lot of thoughtfulness and discussion around the topic.
Thank you for inviting us.
Yes, thank you very much.
All right, well, I think we'll conclude there. For those of you who are going to be able to join us tomorrow in Chicago, I look forward to seeing you there. And once again, thank you, Dr. Ungaru and Dr. Frey.
Enjoy the conference, guys.
Yep. Bye, guys.